Very good morning to all. I am Paresh Prabhugaonkar from Pharmafer. On behalf of Pharmafer, I welcome all the eminent faculty and distinguished delegates who have gathered here virtually for this webinar on role of flow cytometry in plasma cell dyscrasia. I welcome our guest speaker, Dr. Kunal Sehgal. Dr. Kunal Sehgal will share make his eminent contribution for the subject of this webinar today. Also, I welcome our chief guest, Dr. Neelam Varma, who has been kind enough to spare her valuable time with us today. I welcome none other than the most celebrated face of hematology in India today, Professor Dr. B Agarwal. Sir needs no introduction. He is an institution in himself. And I further request Dr. B Agarwal to start the proceedings. Thank you. Thank you all.
Thank you, Paresh, for your kind words. I'll just share my screen. Fine. So good morning to one and all. Today, our guest speaker is Dr. Kunal Sehgal. He's going to speak to us on role of flow cytometry in plasma cell dyscrasias. This webinar is brought to you by Mumbai Hematology Group, supported by Pharmafer, managed by Mice Ideas. I thank Mr. Paresh Prabhugaonkar and his team from Pharmafer, Mr. Rajesh, Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Kunal Sehgal from Mumbai, our chief guest, Dr. Neelam Varma from Chandigarh, discussants of today's webinar who are themselves eminent flow cytometrist, hematologist or medical oncologist, and all of you for sparing your Sunday morning. To introduce the next weekend activities, Saturday evening, 7 p.m. onwards, we have chronic lymphocytic leukemia, then, now, and the future. And the guest speaker is Dr. Varsha Banerjee from Research Institute in Oncology and Hematology, Cancer Care, Manitoba Foundation, University of Manitoba, Winnipeg, Canada. And next day, that's next Sunday morning, 11:30 onwards, we have Dr. Vipul Sheth from Hutch, Seattle, speaking to us on very important subject, CAR-T therapy. And for information of all, the first CAR-T therapy has taken place 2 days ago in India in Attract. Discussants today include Brigadier Dr. Tathagat Chatterjee, Senior Consultant Pathologist, Hematologist, Professor of Hematology and Pathology, Head Clinical and Lab SVS and Dean Academics at ESIC Medical College and Hospital, Faridabad, Haryana. Dr. Ritu Gupta, Professor, Lab Oncology, Dr. BRAIRCH, All India Institute, New Delhi. Dr. Jyoti Kotwal, Chairperson and Professor, Department of Hematology at Sir Gangaram Hospital and Postgraduate Institute, New Delhi. Dr. Tinu Dadu, Principal Consultant, Head Hematology, BLK Super Specialty Hospital, New Delhi. Dr. Jasmina Das, Associate Professor, Hematopathology, Department of Hematology at AIIMS, New Delhi. Dr. Gaurav Chatterjee, MD, HBNI Fellow, Hematopathology, MSc Research, TCM, Hematopathologist, Tata Memorial Center, Parel, Mumbai. Dr. Ankur Ahuja, MD Path, DM Hematopathology, Assistant Professor, Department of Lab and Molecular Medicine, Army Hospital, RNR, New Delhi. And Dr. Afshan Atta, Hematopathologist, Department of Pathology, SKIMS Medical College, Bemina, Srinagar, JNK. Now, to introduce our guest speaker of the day, Dr. Kunal Sehgal. Hematopathologist and flow cytometrist, director, the prestigious Sehgal Path Lab in Andheri West, Mumbai. He received his MD in pathology from PGI Chandigarh. He is recipient of gold medal for the best student at the university during his course. He worked as a fellow and senior resident in hematopathology lab of Tata Memorial Hospital, Mumbai. He was awarded the UICC ICR ETT AUF Fellowship, during which he worked at the flow cytometry labs at Johns Hopkins University, Baltimore, and Seattle Cancer Care Alliance, Seattle, US. He has also worked as a consultant in the Hemat lab at the prestigious PD Hinduja National Hospital, Mumbai, from 2011 to 15. His main areas of interest include flow cytometry and new parameters on CBC instruments. He was actively involved in the development and standardization of 8-color immunophenotyping at Hinduja Hospital and Tata Memorial Hospital, Mumbai. He has actively participated in various flow cytometry associated projects and training courses held at Hinduja, Tata, and as part of the Cytometry Society India and Indo-US conferences. He has presented several papers both at national and international conferences. He is a certified NABL auditor for hematology and clinical pathology. He is a life member and joint secretary of the Cytometry Society of India, an active member of Mumbai Hematology Group and Indian Society of Hematology and Transfusion Medicine. Now for the postgraduates, we have our Sunday quiz. As you know that I'm going to give you the quiz, you have to give the correct reply by emailing on the email ID that I will give you. And the one who does that first with the correct answer will be the winner. After Dr. Kunal's lecture and before we go to the Q&A session, we'll discuss the particular entity and the correct answers. So today's quiz is related to large granular lymphocyte leukemia, LGL leukemia. I'm going to give you 8 clues regarding LGL leukemia, and you have to pick up a false statement. And that statement has a number, 1, 2, or 3. So you have to email that number. You don't have to email the whole statement. You have to just message 1 or 2 or 3, whichever is the false statement. And there's only one false statement. So please don't message too many numbers. And you have to message it to mbagarwal1@gmail.com. mbagarwal1@gmail.com. And it's the fastest finger first. So whoever is the first correct answer gets the prize. And these are the 8 statements which I will read out to you. All of these relate to LGL leukemia. At the top, you have the email ID on which you have to message one of these numbers. Okay. So first one is LGL leukemia is characterized by cytopenia. And cytopenia contributes to the most of the morbidity and mortality. Second, LGL leukemia is often associated with an underlying autoimmune disease, rheumatoid arthritis or others, or it is associated with a malignancy, which may be either hematological or solid tumor. The third statement is there are 2 indolent subtypes, the T cell LGL, which accounts for 85% of cases, and the NK cell LGL, which accounts for 10% of cases. And there is a third type, which is an aggressive Epstein-Barr virus related NK LGL, and this accounts for the remaining 5%. The fourth statement is splenomegaly occurs in about 1/4 of the patients, while hepatomegaly and lymphadenopathy are very rare. Fifth statement is about 10 to 20% of patients of LGL leukemia will have associated monoclonal gammopathy. The sixth one is diagnosis of LGL leukemia is made by combination of 4: clinical picture, morphology, immunophenotyping, and monoclonality assessment. The seventh statement is STAT3 mutation is found in 90% of patients of LGL leukemia. And the last statement is current treatment is based on immunosuppressive therapies And 3 agents are listed here: methotrexate, cyclosporin A, and cyclophosphamide. So you pick up a wrong statement out of these 8, 7 are correct, only 1 is wrong, and give that figure, 1, 2, 3, 4 figure, and email it to the email ID given over here, mbagarwal1@gmail.com. And now to introduce our chief guest of the day. Our chief guest of the day is Dr. Neelam Varma, and we are honored by her kind participation to inaugurate this webinar. There is hardly anybody in this country who does not know Dr. Neelam Varma, and I'm just completing the formalities of introducing her before requesting her to inaugurate our webinar and give few words of wisdom. She is ex-professor and head, Department of Hematology at PGI Chandigarh. She was past president, Indian Society of Hematology and Blood Transfusion in the year 2017-18. Former chairperson, Pathology, Group C departments. Former chairperson, Internal Complaints Committee, PGI Chandigarh. Recipient of WHO Fellowship at Royal Postgraduate Medical School, Hammersmith Hospital, London in 1996. Recipient of ERSAP, that is the Emerging Regions Support and Partnership, presentership for molecular monitoring of CML patients, supported by ICMLF at Royal Adelaide Hospital in 2011. She's also recipient of Dr. Malti Sathe Oration by Indian Society of Hematology and Blood Transfusion in the year 2014. She has published 344 articles in various peer-reviewed international national journals. She's contributed 23 chapters in various books. She has been invited to deliver guest lectures in various international national conferences, and her research interests include clonal hematopoietic disorders, flow cytometry, molecular hematology, and nutritional anemias. And I now request Dr. Neelam Varma to inaugurate our webinar and give words of wisdom for our students.
Thank you, Dr. B Agarwal, for your gracious invitation and kind introduction. I am really honored to be here. We all know the discipline of hematology is a broad and evolving field of medicine, which has fascinated physicians and scientists throughout ages. Starting with discovery of blood cells in the 17th century and description of the different cell types in the 18th century and other so many such landmark events established the foundation on which the entire discipline of hematology has been built. If some of you in the audience ask me now, when did hematology as a specialty begin? I would say that it was somewhere in the middle of 19th century when the development of the microscope and the good staining techniques took place. There is an old proverb which says, seeing is believing. Therefore, microscope and good staining techniques were the minimum requirements for seeing blood cells. Study of blood developed by leaps and bounds as compared to other fields in medicine because blood cells could be obtained so readily via simple venipuncture. Various technologies have changed and vastly improved the practice of hematology over a period of time. The diagnosis of malignant and benign hematological disorders has become more exact now because of these technological advances, and our understanding of the pathogenesis of many diseases also has much improved. It's amazing to realize as to how many details and how many cellular parameters can be studied with the help of all the techniques at our disposal now. Availability of flow cytometry and molecular techniques has made the field of hematology very exciting, very attractive, and challenging for the young trainees in pathology, medicine, and allied subjects. Hematology offers you all a great opportunity to learn and practice this science and serve ailing humanity. Understanding the disease better is the first step in fight against the disease. One of the best examples being plasma cell dyscrasias. Last conference I attended in person was the ISH-BT EHA tutorial we hosted in Chandigarh last February. So although I miss not being able to visit different places in the course of attending conferences, however, during this COVID-19 pandemic, attending virtual conferences or webinars has become the new normal. This gives you the advantage of gaining a lot of information and meeting the friends, colleagues, and students from the comforts of your home. It's very nice to meet the force behind this webinar, Dr. B Agarwal, the faculty, and the participants of this academic activity on this virtual platform. I am pleased to inaugurate this webinar on role of flow cytometry in plasma cell dyscrasia. Wish you all a fruitful and fulfilling experience. Thank you. Jai Hind.
Thank you, Dr. Neelam Varma, for sparing your time, joining us, and giving those lovely words, fantastic words, and great speech. Grateful to you. Thank you. And now, Kunal, it's all yours.
Thank you so much, sir. The outset, like to thank MB Agarwal sir for giving me this opportunity. It's an honor to be part of this MHG meeting. And thank you to the MICE team, Rajesh and Kalpesh. And Neelam ma'am, thank you for chairing the session. It's an honor. You've always been amongst first hematology teachers to inspire us and take us through our journey. So thank you for being there. Also like to thank all my discussants and all the attendees who are attending this session. So during the course of the next 40 minutes or so, I am going to discuss today is the role of flow in plasma cell dyscrasias. Starting from the beginning is just the basics of the plasma cell development. We know that if the naive B cell gets exposed to an antigen, it can either directly form a short-lived plasmablast, or this naive B cell can seed into the lymph node in the germinal center, and this germinal center B cells can then go on to become memory cells or plasmablasts. Now these plasmablasts are the early precursor forms of the plasma cells, which mature to mature plasma cells, move to the peripheral blood, and go on to become the long-lived plasma cells. As we know, these long-lived plasma cells lie in the niches of the bone marrow, the mucosa-associated lymphoid tissues, and the splenic red pulp. Now we'll maybe come back to the importance of the niches, and this is just to give you a brief overview of the journey of the plasma cell. What we'll also need to keep in mind, because this is a talk on flow, is a very basic understanding of a normal plasma cell phenotype. So rather than going into each negative and positive markers, what would like you to remember very basic things. As we all know, bright 38 and 138 is the common thing expressed in most plasma cells. Normal plasma cells are moderate CD45. And if you see in these three figures, the purple color cells are your normal plasma cells, the red color are your abnormal plasma cells. So the normal plasma cells, the ones in purple, will express 19 over here, negative for 56. The abnormal ones are 19, negative, and 56 positive. The normal plasma cells express homogeneous 27. Abnormal plasma cells express dim to heterogeneous or negative 27. Again, 81 expression. Normal plasma cells overlap with the normal green lymphocytes to express moderate 81, whereas abnormal plasma cells will start losing 81. Then you have asynchronous antigen expressions like CD117, CD20, and so on. And we'll see a lot more of this as we go along. This is just to give you a basic background of plasma cells, normal versus abnormal to start with. So the role of flow in plasma cell, I'm going to take you through 3 pointers mainly today. That's diagnosis of plasma cell dyscrasias, prognosis, and monitoring. And the references which I have used today for the talk today are the following. So one is a great paper from Gaurav. Gaurav is here today. Gaurav, Prashant, and TMH team on the review of relevance of MFC in plasma cell dyscrasias. There is another great paper on the applications of plasma cell dyscrasia by Jelinek, Paiva, and team. And I have referred to a lot of presentations, papers, and tweets from these authors. That's Dr. Bruno Paiva, Dr. Alberto Orfaut, who is meetings and conferences in India, Prashant, who's a dear friend, and Dr. Vincent Rajkumar, who is regular tweets on Twitter. So this particular paper by Gaurav, Prashant, and the whole team has a beautiful table, which if one has to summarize in one slide, the importance of plasma cell dyscrasia, or the role of importance of flow in plasma cell dyscrasias. It takes you through the diagnosis, importance of dividing the plasma cell components into normal plasma cells and abnormal plasma cells, the role of various prognostic markers, the role of ploidy, the role of MRD in brief. And this is what I'm going to use as a template for this particular talk and take you through all of these important topics and area in today's talk. So the first things first is the diagnosis of plasma cell dyscrasia or a myeloma or a plasma cell leukemia by flow. And I know in practice we often don't get a plasma cell myeloma sample coming to us for flow if it has classical features of the Krebs symptoms. You have a monoclonal M band, the free light chains are altered, and if the bone marrow aspirate shows you 70-80% plasma cells or even lesser, you have clinched a diagnosis of a myeloma. And in practice, often it is said that, is flow really useful? So my challenge today over the next 40 minutes or so is going to tell you why it is useful and where it is useful and how one can utilize it. This becomes important, especially in our country or scenario where cost constraints are often a problem. So pure diagnosis, pure frank myeloma, it may not be a challenge. However, if you have a myeloma where the morphology is unusual, it may be a challenge. So before going on to how do we do it, these are the broad panels we currently use in our lab. The 8-color myeloma panel was a simpler panel which I used for 4 years from 15 to 19 earlier. This was based on a cytokappa cytolambda tube gating with 38, 138 and CD45. I'll just move to the laser pointer here. So 38, 138 and CD45, 19 positive for normal plasma cells, 19 negative, 56 positive for abnormal plasma cells, and loss of 81 was used for the abnormal plasma cells. We were missing out on a couple of markers like CD27, CD28 and 117, which are very useful. So those were added into the 12-color panel. We also added CD319, which I allude to a little bit as one of the markers which you use when anti-38 therapy is being used. So this is an extra gating marker which we utilize into our panel. So we use the same panel for our 12-color myeloma diagnosis and or MRD. The basic approach, just keeping it brief, I'll not go to the total details. We get out our doublets over here. We look in the forward and side scatter plot. We use the normal lymphocytes as on bright 45 as a reference. Typically, the plasma cell gating as per the guidelines is recommended based on 38, 138. So you'll see these reddish colored plasma cells. And there is a secondary 38-45 gating. You can combine these gates to make AND gates, and then you get a purified plasma cell population. Now, typically, whenever you look at plasma cells, you also want to look at clonality. And as a rule, whenever I'm assessing clonality, I like to mark out my normal lymphocytes in dark green over here, which are my B lymphocytes, 45 and 19 co-expressing mature B cells. And these are my 19 negative bright 45 T and NK cells. So here we have marked our abnormal plasma cells in red. So these are 19 negative, 45 negative. As you see, they are bright 38 and 19 negative. Practically very few normal plasma cells in 19 positive region. In this particular case, the 56 was negative, and I have my internal green NK cells which were positive. And to assess clonality, as I said, we have cytokappa lambda. The mature green cells are showing polyclonality. And when you go back and see the red cells, and with the overlap on the mature B cells, you see a clear-cut cytolambda expression over here. In CD81, you see a heterogeneous loss of expression of 81. It indicates that these are plasma cells. Now, in a diagnostic myeloma, which had 50-60% plasma cells, you got 34% here, the diagnosis is clinching. But take this case for an example. This came to us actually just 10 days ago. 57-year-old male with bicytopenia, reported to have atypical lymphoid cells in the peripheral blood, and the marrow sample was sent to us, saying, please do a flow for lymphoma. That's the only history. We did not receive the direct bone marrow slides for review or the biopsy, just the flow sample, which is often the case in our practice today. So the slides made from the bone marrow slide, the liquid EDTA sample, you see there are cells which definitely look atypical. There are some small, there are some medium to large size cells. Practically all of them have high NC ratio. Some of the cells have a moderate cytoplasm. If you go ahead, some of the cells, as I said, have moderate cytoplasm, but majority are looking like atypical large lymphoid cells or plastic at places. We were fooled, to be very frank. We thought this is a high-grade lymphoma. We were also biased by the history of atypical lymphoid cells, and we said, let's start with our lymphoma leukemia broad a screening panel where we add a B and T cell tube, some myeloid markers, and a CD34. When we attempted this tube, broadly people who do flow routinely will know these are my CD45 bright mature lymphocytes, and I have marked my normal B cells in this pink color, CD19 positive, they are kappa lambda polyclonal over here and shown in this plot. My T cells were normal, they are marked here in green. The majority population was lying in 45 negative. So you know either you're dealing with blast. Now if they are blast, they can be either B lymphoid, T lymphoid or myeloid. The B markers were negative, 19, 20, 10 and 34 was negative. T is very unusual to have 45 negative. However, the T other markers other than 3, 4, 7, 8 were all negative. The myeloid markers were negative. However, if you saw within our lymphoid or leukemia tubes, we almost always have this marker which is CD38. And we saw the 45 negative cells were bright, 38 positive. Subset of them were 56. The moment we saw this, we said, let's retrospectively go back. Would these be plasma cells? So it's difficult sometimes. Plasma cells are known as the melanoma of hematology. It's not easy, but yes, retrospectively, some of them did have a lymphoplasma spread morphology. We did start seeing some binucleated plasma cells. We spoke to the physician at that time. There was no history of or a test availability of the M band or protein electrophoresis done in this case, which was not clinically suspected at time. Yes, the patient did have an anemia and thrombocytopenia, which was not worked up. So we went ahead with a myeloma panel. Again, the red color cells are my abnormal plasma cells on 38 and 138. Practically, there are hardly any normal plasma cells in the light blue, which are 19 positive. Majority of my plasma cells, which were the 45 negative ones, are showing 19 negativity over here. If you see, this is where the bright 38 level comes, and I'm seeing a dimmer 38 compared to normal. The plasma cells have practically lost, all 45 have lost 81. These pink colored cells are my mature B lymphocytes gated over here. So these are polyclonal. And compared to this plot, my cytoplasmic kappa was very nicely and brightly positive. So in a case with a very difficult morphology, it becomes good to have a diagnostic panel for myeloma, have markers like 38, 56 in your other panels so that you don't miss out on this diagnosis. So is the number of plasma cells which we see in flow is important? Does it match to the morphology? This is the typical problem. You will see 50 to 60% plasma cells on morphology, the flow may show 5-10%, and you always wonder why this happened. So this is a study by Bruno Paiva and group in Hematology 2009, where they showed that the median difference between cytomorphology and flow was almost 30%. Having said that, the major problem as proven by the Rostron team, and what most pathologists would agree, that the direct smear made, which is the first pull aspirate commonly, has a very high percentage. We know plasma cells are lipid-loving molecules. They sort of go and be there in clusters in the aspirate as well as biopsy. There's patchy infiltration in myeloma. However, if you make the smear from the same samples, liquid sample, do a morphology count, it is pretty similar to what you would see in flow, or flow may be slightly lower because you will add on to the loss due to cytoplasmic processing if you're doing that, or even in surface processing, some amount of loss and variability will happen. The challenge typically, or the problem mainly, is peripheral blood contamination, and we'll emphasize more and more as we go along. The role of first pull flow, especially for MRD samples, whether it's myeloma or other MRDs, becomes very, very critical. So does the plasma cell percentage have any other significance? Yes, this group particularly analyzed that if you're doing by morphology and you had a cutoff of 30% bone marrow plasma cells by morphology, if they are less than 30% plasma cells, these are the cases in green, they have a better overall survival. Similarly, if you use the cutoff by flow of 15% bone marrow plasma cells by flow cytometry, the ones in green which are less than 15%, better survival. The ones in red which are more than 15% are poorer survival. So they have proposed this criteria that if you are getting more than 15% plasma cells, this is by flow, this is a very high number and an independent prognostic indicator. Now, a plasma cell leukemia case may be obvious in morphology. If you went ahead and did a flow, like in this case, the red colored cells are again my abnormal cells, high forward scatter, bright 38, 138, pretty homogeneous 56 expression seen in this case, lack of 19, which is clearly abnormal in this case, complete lack of 45, and again using my normal B cells 1920 co-positive as polyclonality, I can see that this case was cytolambda positive. Now, one can either visualize a clear-cut plasma cell leukemia, but we know certain myelomas also have, at diagnosis, circulating plasma cells, which will not be enough to label it as a plasma cell leukemia. So Vincent Rajkumar and group in this paper in 2014 have published this cutoff of circulating plasma cells more than 400 in cases of myeloma. And if you see this, the non-dotted line or the linear line over here represent cases where the plasma cell number in circulation was less than 400. You can very clearly see that their performance was far better versus the case which were having circulating plasma cells which were more than 400. So this has been also used, and flow cytometry over there is very useful tool, and we'll be going to circulating plasma cells in details as we go along in the presentation. So the next area or the role of plasma cell comes is, can they be used other than diagnosis? Can they be used for prognosis? Yes, there were numerous papers from the early 2000s, late 2000s. The early papers have to be taken with a little bit of pinch of salt because they were before the advent of novel markers and novel therapies, especially with the large number of therapies available for myeloma today, and that you could the data was old. However, having said that, there are newer data coming in. So I would go to the markers which have been used traditionally. So 28 positive and 117 negative was a poor prognosis marker. CD19, which is normally negative in myelomas, and you will have very rare plasma cell myelomas or leukemias which will have 19 positivity, less than almost 3 or 5% of the cases. They are said to be poor prognostic. There are recent papers on CD81, and I'll share that in the next slide. And then obviously there is a role of ploidy. So CD81 was studied after the advent of novel markers for therapy, and Bruno Paiva and his group showed that both in transplant eligible or non-transplant eligible, in your myeloma case, if the CD81 was negative, you would see both the PFS or the overall survival is better compared to the red cases which are the 81 positive. Now, this has also been studied interestingly in a 2018 study where they combined the prognosis of both markers together, 81 and 117. So 117 positivity is good, 81 negativity is good. So these cell cluster, the cases which are marked green, represented by this green line, are the 117 positive, 81 negative cases. Again, they did far better compared to cases which were 117 negative, 81. And then you have the intermediate cases which had an overlapping phenotype. So clearly they have shown, even in current papers with current day therapy, that having markers like 117 positive, 81 negative could be a good prognostic indicator for these myelomas. Now, this is a pretty landmark paper published by Prashant Ambare team in 2016. We discuss about ploidy. Now, we all know that ploidy done by cytogenetics, hyperdiploidy is good prognosis, and you have the non-hyperdiploidy cases in myeloma. Earlier, when we said ploidy by flow, it was typically done by the typical propionidamide DNA ploidy method. With this publication, there's an advent of using FX cycle violet, and the major advantage is you can combine ploidy analysis along with immunophenotypic analysis. So here in gray are my plasma cells marked in 38-138. In my black are my 45 positive lymphocytes. I measure the ploidy by FX cycle on my lymphocytes, measure that on my plasma cells, overlap them, and you can see clearly the gray plasma cells seem to have a higher ploidy. We calculate ratios, and in this particular case it was hyperdiploidy. And as the data shows, even by cytogenetics in this paper by Prashant, that 58% of the cases were hyperdiploid with very rare hypodiploid cases. So definitely this is a very easy, robust method available. If one wants to do ploidy, and it can be done in a few hours, and we can assess the ploidy, and hyperdiploidy indicates good prognosis. So moving from individual markers and ploidy, let's move to a very, very important part of this talk, which is dividing the plasma cells as part of normal and abnormal and measuring the total plasma cell. So total plasma cell, or the bone marrow plasma cell component, consists of both abnormal and normal in a plasma cell dyscrasia. And whenever we assess plasma cell, whether it is diagnosis or up to MRD, we should try and assess and even document this in our report. And this is what I'm going to highlight in the next few slides, the importance of this. Very early in 2009, early from 12 years ago from today, this has been clearly published and shown that a diagnosis, if a case of myeloma had more than 5% normal cells out of total plasma cells, they did well. So if you see this light color gray line is indicating patients who out of total plasma cells had more than 5%. So if I said 20 plasma cells out of 100, that's 20%, and you said out of those 20, more than 5% are normal, this indicates a good prognosis myeloma versus other cases where there are mainly abnormal plasma cells with very few normal cells. This has been shown both for progression-free survival or overall survival. Now, where did this cutoff come from? It was shown in their data from the Spanish group that only 1.5% of myeloma patients have more than 3% of normal plasma cells out of the total plasma cell basket, whereas 98% of MGUS patients have more than 3% plasma cells. So they said, let's study a cutoff of more than 5% residual normal plasma cells within the total compartment. So again, I emphasize, if you have 100 plasma cells, or maybe out of 1 million cells, you may have only 1% plasma cells in total. Of those 1% are more than 5% normal, it indicates a good prognosis. If they are more than 95% abnormal, indicates a poorer prognosis. This is what I would like you to remember throughout this talk, and this is what they showed. So let's see it in a given case. We had a case come to us with a bone marrow done for staging. The patient had a 1.2 gram within the MGUS category, clinically looked like MGUS, had no CRAB symptoms, no other lytic lesions on the skeletal survey, and the aspirate showed only 6 to 7% plasma cells. So here is the flow. In the flow, we have marked the brown purplish color cells as the normal plasma cells. You see here, these are my 19 positive, 38 bright normal plasma cells, and these are my 19 negative, 38 bright positive abnormal plasma cells. If you carefully see, which is a very common finding one can identify, that the 38 in the abnormal plasma cells is slightly dimmer compared to normal plasma cells. You will see this often, and you'll often see 138 being slightly brighter in the abnormal plasma cells as we go along. In this case, we also see that 19 positive normal plasma cells are negative for 56, and the majority clonal plasma cells are positive for 56. So what did we do? We looked at clonality again, looked at my normal B lymphocytes, mature B cells, they are polyclonal. Assess your normal plasma cells. You see again in the brown color cells, again normally polyclonal, and clear cut the red plasma cells are showing cytokappa positivity. The total events acquired in this case was 260,000. The number of total plasma cells was only 3,193, which is only 1.22% of the total viable cells acquired. Now within this 1.22%, the red abnormal looked more, they were 66.7%, and the normal plasma cells, which here were only 1,000 events, were 33, only 1/3. Now this is almost a very classical finding which you see in MGUS, extremely rare to see this in a myeloma, and if you actually see this kind of percentage, this is a very, very good myeloma, but rarely ever you'll ever see this kind of a thing. So this scenario where a significant normal population of plasma cells is seen in the background as a percentage of the total plasma cell component is a very, very good point to remember and very useful in practice. Now, I'll re-emphasize that majority of MGUS harbor more than 5% normal plasma cells, and this is not the case for myeloma. Now, why is this important? This becomes even more important in smoldering myeloma, and there have been various risk stratifications used by using a combination of normal and abnormal plasma cells. One of the earliest study by Paresh et al. In 2007 clearly showed that if you have abnormal plasma cells more than 95% in MGUS SMM group, you do worse compared to cases which have less than 95. Then others have used a ratio of abnormal to normal plasma cells, and if it is more than high risk, you have a higher probability of progression. Having said that, if I come to smoldering myeloma next, now there are two very useful and very commonly used criteria. One is the Mayo Clinic criteria, the other is the Spanish Petrima group criteria. The Mayo group criteria can be called as a 20-20 criteria. So you have plasma cells more than 20%, M spike more than 2, and free light chain ratio more than 20. Any two of these in a case of smoldering myeloma is high risk. The Petrima group uses the criteria of more than 95% abnormal cells out of total plasma cells in the marrow by flow, and immune paresis, which is a polyclonal immunoglobulin heavy chain which is less than 25% of normal. So this is from Twitter. This was actually just 10 days ago. Dr. Vincent is very active, and he had a thread on his approach to smoldering myeloma, and he clearly showed that patients of smoldering myeloma who have in the high risk category, and you see this red line, these are the high risk smoldering myeloma based on the Mayo criteria. they do pretty bad and have a higher chance of progression. In his follow tweet, he has shown that how the Spanish group has done the Lendex trial. And in this trial, they found that if the high-risk patients were treated with Lendex, so this the blue line is the treatment group versus observation, which has been the norm for smoldering myeloma, you could clearly see a benefit for the treatment group compared to observation group, both in progression-free and the overall picture in these patients. So this clearly highlights it becomes very important to identify high-risk smoldering myelomas. So let me go to a case of which we got. The M band was 2.2 gram per liter in this gentleman. On the aspirate, he had 22% plasma cells. He had no crab lesions whatsoever on all the radiological investigations. Very well worked up case. So if you see, two of these criteria as per the Mayo stratification are met here, more than 2 grams and the bone marrow plasma cells being more than 20%. So he seemed to be high risk. Is he high risk by flow? Let's evaluate. These are my 138 positive plasma cells. Again, I've used that brownish color for the normal, red color for the abnormal. Again, the brown color 19 positive plasma cells are 19 positive, 38 bright. The red ones are 19 negative. The red ones also are 56 negative. Going to clonality again, the brown ones are showing polyclonality. The greens are my lymphocytes in the background, B lymphocytes, and clearly the red ones are cytokappa positive. So you definitely have a clonal component, which is majority, and a non-clonal or a polyclonal normal component, which is very small. Let's look at the percentages. Total plasma cells was 2.58. Again, if you see the direct aspirate smears at 22%, we almost have a 1 log difference between what the direct smear showed versus what the flow showed. So I would say flow should not be used for enumeration of the total plasma cells. We rely on that on the aspirates or the biopsy, which is even better. But as far as the total plasma cells are taken, you divide them into abnormal plasma cells and the normal plasma cells. You can clearly see these are more than 95%. And this, as per the PETIMA group, also identifies this as a high-risk smoldering myeloma, and which the current day random, the RCTs are showing that this may be a group where you may want to take them up for early treatment. So this again highlights the advantage of doing flow. You may not have the advantage of total enumeration, but within the plasma cell component, having more than 95% abnormal cells is definitely a high risk factor for shorter time to progression to myeloma. Now, again, I'll highlight, there have been studies now done that if you have a case of myeloma, and if it has an MGUS-like phenotype, it's also been called like an MGUS-like signature in a myeloma. Now, what does this mean? Is that most myelomas have large percentage of abnormal plasma cells. However, if they have a higher percentage of normal, they tend to do well. And this has been shown in this study of leukemia 2013. Now, the green ones are myelomas at diagnosis which have an MGUS-like signature, which means they have more than 5% normal plasma cells. You clearly see they seem to be doing significantly better as far as time to progression of overall survival is concerned, compared to the red line cases, which are cases where the majority abnormal plasma cells are more than 95 and the normals are less than 5% of the total plasma cells. So moving from the total plasma cell compartment, let's take another area, another plasma cell dysphagia. This is the case which we got bone marrow for staging, plasmacytoma, solitary lesion, rib lesion. Marrow showed maybe only 4 to 5% plasma cells. Again, to highlight, these purplish colored cells are my normal. The red color cells over here are 138, and again emphasizing how the 138 is slightly brighter, 38 is slightly dimmer in my abnormal plasma cells. 319 is a marker which we use for gating currently in the both diagnostic and IMRT, mainly for anti-38, but useful for sub-gating and fine-tuning our populations. The red plasma cells, which are abnormal, homogeneous 56 expression, complete loss of 27, and we looked at 28 dim expression. We went for clonality assessment. My background lymphocytes polyclonal, normal plasma cells polyclonal, and this was clearly my plasma cells showing cytokappa expression. Now, this looks a lot of plasma cells. Why? Because we almost ran it like an MRD. We ran 20 lakh events or 2 million events. So the numbers look big, but when you go back to analyze this, so only 1.1% of the sample. Normal plasma cells were 60%, abnormal were 40%. And we described the marker profile. Now you'll say, why is this important in plasmacytoma and why are we analyzing these percentages and the total assessment? Now this is because there have been now significant studies and work done in plasmacytoma. Like the Quintin and Rostron group had shown that presence of occult marrow disease by flow is a powerful predictor of progression in patients of plasmacytoma. Now, we also have our Indian data. Prashant and team have, actually this is presented into the 2019 MHG meeting, and also at the International Myeloma meeting, this particular oral abstract, that how if you have occult disease in the marrow by flow, these have higher chances to progress to become a myeloma compared to solitary bony plasmacytomas which do not have morphological or flow cytometric involvement. So this is from one of the studies in blood, where they said that if there is no occult marrow disease detected by flow, they tend to do well as far as the proportion of patients who will progress to myeloma versus where you detect occult marrow disease by flow, they tend to progress much faster. So again, the importance being, if you have a sample available for staging, it might be useful for accurate assessment and prognosis in these cases of plasmacytoma. So moving on, I'll touch upon a topic which I have little experience on, but we have had a couple of cases. And actually, in the midst of preparing for this presentation, I learned a couple of things which I'd like to share. Now, this is a very recent and a beautiful article, 2019, again by the Spanish group who have worked wonderfully in all areas of plasma cell dyscrasia. And this is a very nice graph. They show that when they analyzed all their amyloid cases, they found amyloid, as far as the flow cytometry analysis is concerned, to lie in between MGUS like MGUS or myeloma. So they say beautifully that AL, as far as the flow is concerned, lies between the crossroads of myeloma versus MGUS. So what do they mean? They say that some of the MGUS amyloidosis cases by flow can have lower number of plasma cells in the aspirate and have higher number of normal. So this is this corner. So they are called as MGUS like amyloid. Whereas this corner is where you have large number of total plasma cells and a higher number of clonal plasma cells. So they call it myeloma like AL. Why are they splitting this group and having an intermediate group? Because based on their follow-up data, they have shown the amyloidosis cases where more number of normal plasma cells are seen within the plasma cell component, they do better compared to myeloma like amyloid cases which have higher number of abnormal plasma cells. So again, emphasizing on not only documenting and analyzing your plasma cell clonality by flow, but also documenting your normal and abnormal plasma cells within the compartment. Interestingly, this is what I learned during reading on, making this presentation, that what they have highlighted, one of the things which they got as the hallmarks of amyloid by flow was lack of homogeneous positivity or negativity for 56, reduction of B cell precursors, and they explain how there is a fight for the niches in the bone marrow, and when plasma cells start multiplying, the B cell precursors and niches go away, and that predominantly there is a clonal plasma cell component with very few normal cells in majority of amyloid cases. So this is a case, I've had only 2 cases of amyloid. This is actually a doctor who had cardiac dysfunction, was assessed, had fat pad biopsy done for amyloid, was positive, and a bone marrow was done for staging. The aspirate showed only 4% plasma cells. And if I see this flow, again, my normal plasma cells here are marked in the sky blue or teal blue color. My abnormal ones are again in red. The 138, 38 positive. They do not show 56 in this case. They show some heterogeneous 81 expression. Majority are losing my CD19 over here. And if you see normal plasma cells are 19 and 27. They are clonal on cytokappa compared to my background polyclonal B lymphocytes and my plasma cells. So the importance was what I learned, again, what they highlighted, the lack of 56 expression. Now this is where my hematogons come. This is almost like a blank empty area, which I'll show you in the other cases how we beautifully get hematogons over here, and those were absent in this case, and predominant majority population was abnormal plasma cells. We actually also assessed the MRD for this patient, and it was positive at the end of 5 months. And there are new papers coming in again by the Spanish group of role of MRD and amyloid using multicolor flow. So this is just to complete the case. This was the bone marrow biopsy. It was, I've never seen a biopsy so packed with amyloid. Basically, the cellular component is hardly there. This is all the pink color structure you see in the background. The photo is not doing justice to this case. And I'm sorry, I couldn't retrieve the Congo red, but this is the pale pink fluffy material in the background, practically completely replacing normal hematopoietic elements. This is a vessel, and you can beautifully see the perivascular amyloid in this case. So moving to the next and the latter and the more interesting half of where flow has really made its presence felt in myeloma is MRD. We currently know the current IMWG criteria for response to myeloma have now a new criteria which is called a stringent CR. And basically stringent CR, in addition to having CR, also asks for two things: a normal serum free light chain ratio and absence of clonal cells in the marrow. When I went earlier in the books, the clarity was not there whether it meant by clonal in the flow or clonal by IHC. Most data represents that this assessed clonal by IHC. So the Spanish group went ahead and wanted to show the role of flow being used and the flow remission or immunophenotypic remission of flow negativity. Now this is prior to the new 2016 criteria. This is a 2008 paper where there was only definition of CR, there was no stringent CR. So what did this group show? That if you did flow and found MRD negative, and this is your first and second generation 4-color flow, this is not the 8 and the 12-color flow. Even with the 4-color flow, they said this particular line of patients who have MRD negative by flow did far better than the ones which are MRD positive, and this is the complete remission group. So if you have progression-free survival or overall survival, if you have an immunophenotypic negativity, they do better even if they both have a complete response. Now, this is a very interesting paper in JCO, again by Bruno Paiva and group. So they combined stringent CR. So this is as per the new guidelines, and the stringent CR where the IHC in bone marrow biopsy is used, and they combined it with immunophenotypic response. So this non-dotted blue line, this one over here, clearly shows to be a separate picture, and the other areas, so other patient groups, which is CR but no flow response, negative, still MRD positive with CR, and the non-stringent CR plus MRD positive. These seem to be doing worse. So this interesting groups of patients in their study, like to highlight the yellow triangle is M component positive, means the M band is still there in blood, and the blue is the M component negative. Now these 7 subsets are patients who had immunophenotypic response, but still if you see the yellow color M band is present. But what did they see? You are seeing a deeper response supposedly by flow, but M band is still there, and we know the M band can persist. And in all 7% patients, as they went along, the M band disappeared. If you see the blue triangle on follow-up. Now there's a reverse of patients who seem to be by stringent CR M band positive, negative. So you have the blue triangles in all these patients. That means the M component is negative. However, they were negative. They were positive on flow, so that is non-immunophenotypic response. So again, positive by flow, but M band is negative. If you carefully see, majority of these patients went on to develop an M band later in their progress, indicating in this study that if you had an immunophenotypic response which was negative, that meant good prognosis, and if you had immunophenotypic MRD positive, that meant bad prognosis. Then the question came, to what level of MRD do we go? And that is the challenge today. Do we use, and what methodology do we use? Now, we know the disease at presentation to when we level it, we checked it MRD at the end of therapy, and we can go deeper and deeper. But what does it mean? And what are the caveats which we see? Now, you may see a patient in CR who is immunophenotypically positive because he may not be in stringent CR. They may relapse. Or some patients, actually we have seen, and these are the MGUS-like myeloma patients, who may have a sustained CR, irrespective of what their phenotype is. These are actually the good prognostic ones, and the work has been done to identify these patients who, in spite of an MRD positivity, may still seem to do well. Now, you may have other categories where even a deeper MRD negative response, these patients may have a sustained relapse, or they may not be able to sustain a CR. And this may be attributed to their age and high-risk cytogenetics, or some patients end up doing very well with a deeper, not so deep MRD, but you still end up doing well, again, because they may have a very good cytogenetic and good characteristic features. You may go deeper into the MRD as low as 10⁻⁵ and -6. That does not mean these patients may not relapse. You may still have a late relapse. However, if you go deeper and deeper, now data is coming in that this, with the advent of novel drugs, can be aimed for operational cure. Now, that is the challenge which we need to see in the forthcoming trials. So the importance of, depth of MRD was beautifully shown in this paper by Andy Roston. What did they do? They categorized their follow-up patient samples by logs. So this category was the worst category, it has more than 10% residual cells. As we go along, the next category is 1 log lower at 1%, then 0.1, 0.01, and less than 0.01, which is 10 to the minus 4. And as they went across the categories, the lower the category, the better the patient performed. So they showed that the depth of MRD is very critical for both progression and overall survival. So this is the line which showed the 10 to the minus 4 category or less than 0.01 does much better compared to the others. So Bruno Paiva and group took it one level deeper by using next generation flow. This was a study done in elderly patients. It was a very beautiful paper, again showing that actually if you go deeper, that is MRD less than 10 to the minus 5, that is MRD negative. These patients do very well compared to patients who are in the red category, which seem to be 10 to the minus 4, more than that, less than 10 to the minus 4, but more than 10 to the minus 5. That is between 0.01 and 0.01. So even it's a significant level of MRD because they do worse and almost similar to other levels of MRD. So again, indicating the deeper we go for MRD, if it is MRD negative or undetectable, and you need to have the newer next generation flow methods to go deep. And this is where they have shown in their data, they seem to perform better. So this 2 slides, the idea of showing you, or the focus was that we need higher sensitivity, we need to acquire more cells, and then has been the advent of the Euroflow group, what they have shown next generation flow, and I'm sure many of my colleagues in the country are already doing this. Dr. Ritu is here, Gaurav is here, and I know that both these labs are doing the NGF and many others too. So this is again some data coming in by use of the next generation flow. This is the depth of MRD. The blue patients are undetectable MRD, and and the red patients are where they are MRD positive. Again, progression-free survival, overall survival, you see that these patients who are MRD negative do better. So there is no doubt that undetectable MRD seems to be a very, very important prognostic indicator. Now, this was a very interesting paper, was done in elderly patients in the non-transplant eligible settings. Now, what I learned from this paper was 2 things. That the impact of MRD on cytogenetic risk factors and the age. Now here you see the blue line and the black line, these 2 are standard risk blue line and the high risk. Now these were standard and high risk which are MRD negative, and the yellow and red are standard and high risk which are MRD negative. So even if you had high risk cytogenetics, MRD negative with the advent of novel therapies and treatments ameliorates the risk of the high risk patient. Similarly, in this study, they used the age group of 65 to 75 or more than 75. And you see again, whatever be the age in this study, being MRD negative seemed to be a better prognostic indicator compared to MRD negative. So emphasizing that MRD negative is good, and this has led to new IMWG criteria for MRD. Now they have put in forth a new criteria which is called a sustained MRD negativity. Now, this means MRD negativity by the high sensitivity next generation flow or NGS or both, and by imaging with 1 year apart. Because now there has been data that you need to do MRD not only at one time point, maybe a second time point will be useful, and these are sustained MRD negatives. Then they have defined flow and NGS MRD negative, and then there is also the important definition of imaging MRD negativity plus MRD negativity by NGS or NGF. So my understanding, very briefly, from a current very practical clinical scenario in private practice, when people ask me, well, you think MRD will help? Currently, MRD as a treatment indicator is being used in clinical trials and has to be evolved, has to be still looked at. But I think there's enough data to say that MRD negative cases generally means a good prognosis as far as better progression-free survival, overall survival. My understanding says it indicates improved outcome irrespective of therapy use and irrespective of the risk category as shown in the Bruno Paiva paper I just showed earlier. So I'd like to show you how, a couple of cases of MRD which we have used in our lab. So again, the same panel, as I said, addition of CD319. The challenge in private practice is if the patient is given therapy, we don't really get to know what therapeutic drugs were used. And we have come across 2 or 3 cases based on our 38 gating of monocytes, which we use our internal control now. We realized the monocytes were 38 negative, which made us ask the clinician, was a daratumumab given to this patient? They said yes, and we found this CD319 as a very useful marker. There is data from Prashant and team, Dr. Wallace, the Euroflow group on various markers, 319, 229, 54, and VS38C. Both Prashant and Dr. Wallace's papers show 319 as the better marker. I went by their word. I've been using it and it's been quite useful. So this is a case of myeloma MRD. Again, my light blue cells are my normal plasma cells gated on 3845. Now this is my 138 gate. My red cells over here, which have come from my bright 56 gating, negativity for 27, negativity for 19, are my abnormal. If you go back, they are dimmer 45. Normal plasma cells are 19 positive. Abnormal plasma cells are 19 negative. And this is a nice plot to show normal plasma cells 1927 positive, abnormal plasma cells in this case were 19 negative. Again, they look a lot of plasma cells, but these are 2 million events. And in 2 million events, we also saw the abnormal plasma cells showing some heterogeneity for 81, but not a lot. Predominantly, this is almost like an 81 positive pattern. Again, we get my mature B cells in blue over here, some hematogones in dark green. You can see polyclonal mature B cells. In the background, you can see the light blue polyclonal normal plasma cells, and then you have the red gate. Sometimes you need to make use of these axes to separate your polyclonal cells, and then you can clearly see that the red color cells are cyto-kappa positive. Now, this is the report which we give for a myeloma. We indicate the history and treatment therapy given to us. The 12th machine which we, protocol which we used for washing stainless wash. This is not the NGF. I am still using a stainless wash and modifying it to get 2 to 3 million events now. The viable events in this case were 19 lakhs, which was my denominator, and you see 190 were my MRT events, and my percentage is as low as 0.0098. We document when we have a negative or positive report, what is our LOD and LOQ in our report. This becomes important to the clinician because he needs to know to what depth the MRD has been reported to. You may do at 10 to -4 or -5 or -6, but it is important for the clinician to judge and make his own interpretation. So hence giving the LOD LOQ for this assay becomes important. We are also trying to gauge within the MRD or within the marrow compartment, even in an MRD case, what are the total plasma cells, what are the normal plasma cells, and what are the abnormal. There is some data coming along that within the MRD cases having a higher number of normal plasma cells seems to indicate a good prognosis again. So having said that, in the last 5 minutes, I would like to end with some caveats in MRD. It is not so easy. This requires a high degree of skill and experience. You require to standardize. There are cytoplasmic kappa lambda is a tough job. You need to standardize it very well and have it going. This is another caveat which I would like to show. Though I started with the basic immunophenotypes, here my plasma cells are being gated in this golden brown color, and my green cells are my mature lymphocytes. You see the mature lymphocytes are polyclonal. What I want to take you to is to the 1956 plot, and you see normally the way I have taken this talk today, I would have said, okay, these are my normal 19 positive, 56 negative normal plasma cells. These are my 56 positive, 19 negative. They could be abnormal, and then there are some. What are these cells? Plasma cells, but they are 19 and 56 negative. The challenge is when you start acquiring a lot of cells. Now this is my population which I'm exploring in this case. It looks 19 to 56 negative. Yes, it is polyclonal on kappa lambda, looks normal. We get it on 19 negative 56 negative plasma cells. They are also polyclonal. And when we get it on 56 positive 19 negative, they are also polyclonal. The caveat which I would like to say is that even in books, it's clearly given, sometimes given in small print, one needs to know when you start acquiring a lot of events, 1 million to 5 million for MRD, you will start seeing some normal population of cells, plasma cells, which normally can lack 19, can lack 27, can have 56. So hence, the take-home message is whenever analyzing plasma cells, and I say this whether you're doing diagnostic or MRD, it cannot be based on 1 or 2 markers, presence or absence. It has to be based on presence of simultaneous and multiple aberrant phenotypes detected by flow. The last few slides is the future of flow, and I'm just touching. I have no personal experience, but I know this is the major area of interest, and I would refer you to this paper. This is what I also read before this presentation by Alberto Orfao and group. This is a recent paper, and they go into the details of the importance of circulating tumor plasma cells. They've showed the importance of various methodologies which can be used, from cytomorphology going to second generation and third generation flow, going to PCR and NGS, how they are showing the depth of response improves based on which method you're using. What they have highlighted and cross-referred to their other paper is that by doing NGF, they found circulating tumor cells in the peripheral blood in almost all cases of myeloma and smoldering myeloma, significant proportion of cases of MGUS, and very few cases of plasmacytoma. Basically indicating if you have higher number of circulating tumor plasma cells, it indicates a adverse prognosis. So this is what they have highlighted as the potential clinical implications. So if you have circulating tumor plasma cells, it indicates sign of activated and disseminated disease. As I said, there are more number in myeloma compared to smoldering compared to MGUS. Higher circulating plasma cells indicates adverse prognosis both for newly diagnosed cases of MGUS and myeloma, which is what they are showing in their papers. And they have also showed the prognostic value of these circulating plasma cells is independent of the age, cytogenetic and risk factors, both at diagnosis and at follow-up. Interestingly, they've also showed in their paired studies, when they compared the circulating plasma cells with the marrow MRD status, that this still holds to have a independent prognostic impact. Now, they have done some studies where they have come out with a cutoff of 0.058% plasma cells, which I share. And they've also proposed this schema saying that you can see a blood smear morphology if it's a clear plasma cell leukemia. So you have circulating tumor plasma cells by morphology, you don't need to do flow. If it does not fit the diagnostic criteria by morphology on plasma cell leukemia, one can look at doing flow on the peripheral blood. The major reason, the major importance of peripheral blood flow and why everyone is interested, this is non-invasive. Okay, if you do flow and you have presence of circulating tumor plasma cells, what is the number? Based on a study which they have done with 80% sensitivity specificity, they propose if it is more than 0.058, this generally indicates myeloma or high-risk MGUS. Obviously, you need other clinical criteria and marrow aspirate morphology and staging criteria. If it is less, it indicates an MGUS or an MGUS like myeloma. If you don't find circulating tumor plasma cells, it is highly likely, and this is by NGF. So keep in mind, this is not by a routine method, this is by a NGF method where you actually acquire almost 10 million cells. If you don't find, it is more likely to indicate MGUS or a localized disease. So that's where I would end with the future, and I would just summarize with this slide. What I've tried to show you today that flow cytometry is useful for diagnosis, especially in cases with difficult morphology. We discuss individual markers of employability which can be used for prognostication. I emphasize, and I still emphasize for me personally, what has been a really learning curve in the last 2 years and which I found very useful is to divide plasma cell compartment into the normal and abnormal plasma cells. And I foresee this to be very, very important as we go ahead in patients of MGUS and smoldering myeloma. We discussed the role of staging in plasmacytomas. Again, sounds very interesting. Amyloid, though I have less experience, this is some area which we need to work on. MRD is the most challenging but seems to be most rewarding as the most important prognostic factor. And as I showed in some papers, it seems to be ameliorating the risk of age or cytogenetic risk even in the non-transplant elderly population. And I think the future does lie in circulating tumor plasma cells. And I would be happy to take the experience of the discussants in the group who would have more experience in this than me. With this, I would like to acknowledge my whole team. Shweta, Archana, Florence, who's not in this group, who have been doing my flow and shown all the plots, thanks to them. Neha, who's been with me the last 5 years. Manjusha, who's not in the picture today. And it's their hard work because of which I could present this talk. Thank you so much. And I'll be happy to take questions after the session.
Thank you, Kunal. Great talk. You really brought flow cytometry to the clinicians in their hands for day-to-day practice. All aspects covered so beautifully in a short time that was available to you. We'll give you some rest for 10 minutes and take up the question answer session after we sort out that quiz that we had put for the PGs. So I'll just share my screen. So going with the quiz was related to LGL leukemia. You were given 8 clues and you were supposed to pick up one false statement. And there are 8 statements which were shown to you, and I'm not going to read them again. Before I come to the correct answer and name of the winner, let me tell you something about this entity, LGL leukemia. So this is an indolent lymphoproliferative disorder In 2016 WHO classification, it is recognized as cytotoxic T and NK cell lymphoma leukemia. The T-LGL and the NK-LGL account for 85% and 10% of cases respectively. So that was one of the statement made, and that was a correct statement. A rare kind of LGL proliferation is aggressive NK-LGL leukemia, and that accounts for about 5% of patients. It is associated with EB virus. It is mainly seen in Asia. It affects younger people. Its prognosis is poor. And that was also a part of the statement made in the quiz. The clinical profile of these patients. First, look at the left side. The median age is 59. Male, female is equal. Again, large number of patients are T-LGL and a small number are NK-LGL. Majority of patients, 81%, at initial diagnosis are already symptomatic. 24% have splenomegaly, and that was another statement made in the quiz, that 1/4 of the patient has splenomegaly, and hepatomegaly and lymphadenopathy are very rare. These patients have neutropenia, and 1/4 can have very severe neutropenia. And this is a hallmark of clinical picture, because of which they'll end up with infections and even die of infections. And then, of course, some have anemia and some have very severe anemia. And patients of acquired pure red cell aplasia should be searched for LGL. And some have thrombocytopenia. About 10% of patients have associated monoclonal gammopathy, and that was another quiz statement that was made. So that was also a correct statement, that yes, MGS is associated in 10% of patients. And good number have collagen vascular diseases, of which commonest is rheumatoid arthritis. On the right side, you see the associates. And I put something in the red boxes. The autoimmune diseases, 15 to 40%. Solid or hematological malignancies in almost about 10% of patients. And these could be either solid or lymphoid malignancy, usually B-cell lymphoid malignancies. And that was another statement made, that these patients have associated autoimmune disease or malignancies. And as you see over here, out of autoimmune disease, the commonest is rheumatoid arthritis. In fact, Felty syndrome may be mistaken for this particular entity. Coming to the diagnosis, diagnosis is based on clinical picture together with 3 lab important aspects: the morphology of the cell, the flow data of the cell, and documentation of monoclonality. And then, of course, molecular studies can be of help in today's era. And that was another quiz statement, that to make a diagnosis, you often require morphology, flow, and monoclonality documentation. That's the morphology. And you see the cell here. So these cells are large cells, 15 to 18 micron. There is abundant cytoplasm. There are classical azurophilic granules. The nucleus is reniform or round, and the chromatin is mature. And of course, these are cytotoxic lymphocytes. Now, the threshold of number of these cells to be present in the peripheral blood has been significantly lowered. 500 cells per cubic millimeter are enough. Only half of the patients really have lymphocytosis or hyperlymphocytosis. It is not possible visually under the microscope to distinguish between a normal LGL and a clonal LGL. And hence flow is required. And the flow has typical characteristics of post-thymic mature effector memory cell phenotype. The T cell LGL will express CD3, CD8, and CD57, while the NK will be negative for CD3, CD8 plus, CD16 plus, and CD56 plus. This is the classical T cell subtype shown in the green. It is CD3 plus, It is CD5 dim, CD8 plus, and CD57 plus. And that's the classical NK cell subtype. The circled here, these are CD3 negative, CD8 negative, CD16 positive, and CD56 positive. Finally, the diagnosis is confirmed by detection of clonality, and that helps you in differentiating a reactive LGL proliferation from real LGL leukemic proliferation. And this is of utmost importance in clinical practice when a patient, say of rheumatoid arthritis with a little splenomegaly with some cytopenia and has got these cells which have been documented by flow to document their monoclonality. TLGL can be easily tested because of the presence of TCR rearrangement, but it is difficult to document the clonality in the NK-LGL. And you can see the clonality study over here. You can see a single peak in green. STAT3 mutation, and that was another clue in the quiz. STAT3 mutation has sort of given a new angle to the pathogenesis of this particular disease. And you can use the sequencing to document the STAT3 mutation. It has become of significant importance from multiple angles, which we will review a little later. What's the differential diagnosis? And for a clinician, this is of utmost importance because you are talking of a rare disease from the ocean of common day-to-day problems. So one of the group is the reactive LGL proliferation. And this is really an ocean. Various viral infections can do this. There are just three named over here: HIV, EB, and CMV. Various malignancies can produce a reactive LGL, solid tumors, non-Hodgkin lymphoma. This can happen after splenectomy, and this can happen after both solid organ transplant and bone marrow transplant. So this is a huge number of patients having reactive LGL proliferation. These reactive proliferations are either poly or oligoclonal. One important thing for the clinician is the sooner or later it disappears. It does not last forever, never in years, and that helps you if you are not very comfortable in making a diagnosis at initial presentation. Another important thing is that the reactive LGL proliferation does not have cytopenia as a part of it. You can always have rheumatoid arthritis with anemia of rheumatoid arthritis. That's a different story. But cytopenia due to LGL infiltrating the marrow is not there. And bone marrow biopsy comes to your rescue because in reactive, the marrow infiltration by LGL is virtually absent. Now, this is the classical problem in the clinical practice. You have a patient who's got an immunological disease like rheumatoid arthritis, and he has developed LGL. Versus you've got a patient of rheumatoid arthritis with splenomegaly, with leukopenia and neutropenia, the classical Felty syndrome. And you can easily make mistake between the two. The classical differences are listed here. A rheumatoid arthritis developing LGL will have increased risk of leukemia. You can show monoclonality, and this problem is increased by doing splenectomy. In Felty syndrome, the counts are low. There is erosive arthritis. There are extra-articular manifestations of Felty. There can be recurrent infections, and this rather improves by splenectomy. And then there are overlapping areas where there are immunological finding and there's a splenomegaly. It's all right to talk in a classroom. In clinical practice, this is very tough area. The second differential diagnosis is the bone marrow failure syndrome. Patients of acquired pure red cell aplasia, acquired aplastic anemia, PNH, and MDS. That means almost all sorts of bone marrow failure syndrome can be associated with LGL leukemia. And you've got to look for that, you've got to search for that, and you have got to go beyond morphology. STAT3 mutation is found also in few patients of aplastic anemia and MDS. And it's possible that the pathogenesis of these disorders overlap as shown in this particular cartoon. You've got LGL and you've got STAT3 MDS, PNH, aplastic anemia, PRCA, and STAT3 can be positive in them. So to put all this together, you suspect LGL when there is a clinical picture, neutropenia, recurrent infection, anemia, underlying autoimmune disorders, especially rheumatoid arthritis, and of course, you are blessed if there is lymphocytosis. Then you do the careful examination of the peripheral smear, and you pick up these large granular lymphocytes. And then you investigate further with the help of clonality and STAT3 mutation studies, and your patient may come out to be reactive, may come out to be neoplastic, or may still be in the gray zone. So if you document a reactive LGL proliferation, then these could be patients of viruses, transplants, and splenectomy. And if you document that this is a true clonal LGL expansion, this could be T or NK, and you documented the clonality. And if you still need additional test, you can do STAT3 mutation. And then there is this huge ocean of gray areas. You got low LGL counts. You do not have evidence of clonality. You do not have a STAT3 mutation. Patient has pancytopenia, lymphopenia. You do the bone marrow biopsy and do immunohistochemistry. You find subtle infiltration of LGL in the interstitium and intravascular areas. And this is cluster of CD3+, CD8+, or the lymphoid nodules. What is the pathogenesis of this entity? So we not exactly know the pathogenesis, but it is sort of evidence-based that probably the whole thing starts with a chronic antigenic stimulation, like rheumatoid arthritis, like patients of chronic viral infections, or even a malignancy. So virus or other antigen. This leads to a polyclonal LGL expansion, and this may ultimately pave way to the clonal LGL proliferation. And then you've got this STAT3 mutation in the FAS, as a result of which there is anti-apoptosis and cells don't die and accumulate. This is another cartoon explaining you the pathogenesis. So you've got oligoclonal cytotoxic lymphocytes population resulting from an unknown antigen or a known antigen. So various kind of chronic antigen stimuli or an unknown antigen leading to STAT3 activation or mutation. But monoclonal cytotoxic lymphocyte population having STAT3 activation or mutation, and there can be three types of outcomes. And the down at the bottom is the one which is STAT3 mediated, where apoptosis is stopped and you have a profound accumulation of these cells. And last part is the treatment. And you had a statement in the quiz that the treatment is not anti-neoplastic agents, but immunosuppressive agents. And that's true. Patients are treated with either methotrexate or cyclophosphamide or cyclosporine, not for their anti-neoplastic activity, but for their immunosuppressive role. Like rheumatoid arthritis, patients are treated with methotrexate. So if your patient has rheumatoid arthritis with LGL leukemia, the drug of choice will be methotrexate. If your patient has got pure red cell aplasia or anemia as the presenting feature with LGL, your drug of choice will be cyclosporine. You do not want to suppress the hemoglobin production further, and cyclosporine is relatively specific for pure red cell aplasia. Cyclophosphamide is the only agent which is known to reduce the clone of LGL. And there is sort of suggestion that if a younger person who can tolerate cyclophosphamide easily, then that could give you a longer survival. The median survival of LGL is just about 10 years. So a younger person, you probably go for something better. 30% is the response to each one of these agents. People have tried to give them in combination, but did not achieve more than 30% results, and there was only toxicity. So these are sequenced. You may start with cyclosporine, go to methotrexate, go to cyclophosphamide. You may start with methotrexate. Once it fails, you can go to cyclosporine and cyclophosphamide, etc. So overall, you can help about 70–80% of patients for quite some time by using them very carefully in a sequential fashion. Once all these fail, there comes the role of chemotherapy, and the T-cell targeted chemotherapy include drugs like cladribine, fludarabine, or even alemtuzumab, which of course is not so easily available and toxic. And there are some young patients who are even candidate for transplants, and they have been done with some success. Coming back to the options which were given to you, the statement that was wrong or false was the STAT3 mutation is found in 90% of patients. So it's not like BCR-ABL, it's not a marker for CML. STAT3 mutation is found only in about half of the patients of LGL leukemia. But because it is found in half of the patients, it does become a very good marker. But there's no other condition in hematology where STAT3 mutation is present to the tune of 50%. And there are articles showing that this may be present even up to 70%. It depends upon your technology of sequencing. So the correct answer was 7. Now telling you the winners of the day, and there are a good number. We usually used to have 10 to 12 correct answers out of 100 plus who used to try. This time, almost 150 plus have tried, and we have 24 correct answers. But it's my duty to read out all those 24 names to you. We have Dr. Lalita Jyotsana, Dr. Amit Khurana. These are all one who have answered correctly. Dr. Abhishek Sharma, Dr. Mayet Marier Shaw, Dr. Christopher Liam, Dr. Andre Kurnavan, Dr. Virti Shah, Dr. Neha Banot, Dr. Hari Priya, Dr. Apesha Kapadia, Dr. Gunjan Prasad, Dr. Gurmeet Singh, Dr. Ramesh, Dr. Krish Kanan, Dr. Abdullah Al Musabir, Dr. Sutharan Kanan Ramamurthy, Dr. Aishwarya Raj, Dr. Kamal Patel, Dr. Vineet Chand, Dr. Priyanka Dhende. And now I come to the 4 names who answered within a minute of completing the quiz. And their differences are of few seconds in answering the correct ones. And these 4, and they answered at 11:39 a.m. And these 4 are Dr. Lakshita Singh, Dr. Andy Tang, Dr. Abhishek Gawande, and Dr. Thusita Kumarasiri. And out of you 4, all 4 of you are correct. All 4 of you have answered at 11:39, but Dr. Thusita Kumarasiri is ahead of the remaining 3 by few seconds. So the winner today is Dr. Thusita Kumarasiri from Sri Lanka. Congratulations to you, and you will get your prize. So that was the quiz, and now we have our faculty to discuss and have questions for Dr. Kunal. And we'll begin with Brigadier Dr. Tathagat Chatterjee.
Can you hear me, sir?
Yes.
Yes, sir.
So a very simple scenario, a real life scenario actually, where nephrologists, hematologists, clinical hematologists, every one of us are involved. We have not yet been able to give the solution to this young 36-year-old male who is the husband of one of my MD students. So he had a RT-PCR COVID positivity in April this year. He became negative after 1 month, and now he's got chronic renal failure. And various parameters, just important parameters are the protein clearance ratio, which is more than 5.30, and his nephrotic range proteinuria. So all the tests were done negative so far, except that there was an M spike that unfortunately has not been quantified in the 24 hours urine protein electrophoresis. So with this in mind, and we have already taken about 25 days in this patient whose kidneys are possibly packing up. So are we dealing, you are a hematopathologist and a flow cytometrist. Should we go upfront with a bone marrow aspirate till the nephrologist decides on a kidney biopsy, discuss the clonality on the flow cytometry, and possibly think of this as either a monoclonal gammopathy of renal significance post-COVID or a transient plasma cell dyscrasia post-COVID? Your thought on this?
Thank you, sir. Sir, very little experience on whether it is transient COVID versus actual cases of light chain MGUS or MGRS. Having said that, from the history or describing side, it seems that it will be very important to document on IFE, unfortunately, before we go anywhere ahead, to whether this is really a light chain or there is actually a heavy and light chain combined, because both the definition of light chain MGUS or an MGUS will change. Now, having said whether it is either MGUS or MGRS now, I think flow will definitely have a role to help. Because, for example, in MGRS, we know there can be either a B cell clone hanging in the background, or it could be actually a plasma cell clone. And from my little understanding on the clinical side, the treatment modalities used for the treatment of this may be slightly different. Now, if you go on to do an IFE, confirm the MBAD and still do it, I assume whether the nephrologist does the kidney biopsy or not, the bone marrow will end up being done for staging. And if it is being done for staging, I would advise flow would be useful in such a scenario. So that's what I can best.
I think, thanks. I think that's a very, very practical advice. And we have actually asked that go ahead with the bone marrow aspirate and biopsy, and let us do the clonality studies and see what exactly the bone marrow shows till the kidney biopsy follows.
Correct, sir.
Thank you.
Thank you, sir. I think Agarwal sir is there, or is.
I have finished my question, so the next panelist can take over.
Maybe
right. So, hello Kunal, I congratulate you on a very lucid and an informative talk.
Dr. Ritu will wait and take a question from the audience.
Yes.
And we'll come back to Ritu. So Dr. Abdullah has asked a question. What is the minimum number of events required to accurately interpret MRD?
So the current guidelines from IMWG and the European data which is coming out from the Spanish group is saying that in MRD we need to go as deep as 0.001 or even below. They are targeting that the limit of detection should go below 0.001 up to almost a 10⁻⁵ or -6 range. If one needs to go below, you need to reproducibly acquire almost 3 million to 5 million events on a regular basis. So that would be the number of events required. But again, it also depends on the number of, what is your sensitivity target. So if that is the recommended target, then that's 3 million to 5 million events.
Thank you. I'll take one more question from the audience. Dr. Mamta Yargov wants to know what should be the criteria to decide the extent of hemodilution of marrow to decide the type of PCD.
So that's a good question. Answer in two parts. I don't think the enumeration which one does from flow can be used to decide which PCD it is. As I said, even in myelomas, MGUS or smoldering, we might get 1 to 3% plasma cells on flow. So as far as the enumeration is concerned, that needs to be done on the direct smear, the bone marrow biopsy, and the other criteria. The challenge of hemodilution is always there. Now, the other part of the question is how do you assess hemodilution? In the background, when you do a flow, especially when you're doing multi-parametric flow, you can assess normal myeloid blast. If you have 117 in your panel, 117 and 38 are very useful. 117 can assess the bright mast cells. With 19, 38 and 45, one can assess the B cell precursors, which are hematocones. And obviously you have the background neutrophils there based on site scatter. So, assessing all 4 of these can be used. There are some papers coming in that what is the minimum number of mast cells or plasma cells. But again, they are dependent on techniques. The normal ranges are difficult to define. But if you don't see any mast cells, if you don't see any background precursors or marrow elements, the value of that MRD negative report might be a little iffy.
Thank you. Dr. Ritu, go ahead with your question.
Yes, Prashant, thank you for a very lucid presentation. And as you very rightly pointed out towards the end of the talk, the caveats in the MRD assessment. And one very major thing is the hemodilution. So my question is a bit related to what should be our future recommendations. So what do you think is the role of guided bone marrow aspirates for response assessment in multiple myeloma as opposed to the random that posterior superior iliac spine bone marrow aspirates that we currently do?
It's a very good question. Again, I don't have a definite answer to in terms of experience. Again, in a prior practice, that is very challenging. But I agree, there should be some kind of work being done in form of a trial towards that. Also, answering the question of the hemodilution, I think the cannot be stressed more upon is the first pull aspirate. Traditionally, everyone when does the marrow takes the first pull on the slide. But when for assessing MRD, I would say the whole game is for MRD. The first 0.5 to 1 ml, 2 ml, whatever you take should be taken into the MRD vial and labeled so. So that is where I would say definitely will help assess. And I think we as an Indian group should get together and make some consensus guidelines as far as how we are all evaluating. Marker I found 117 very useful. I didn't have it in my earlier panel. More than diagnostic or prognosticating myelomas, I think the assessment of mast cells in the background has been extremely useful when doing myeloma MRD.
Thank you. We'll take one question from audience again. Dr. Sarita Pradhan wants to know, kindly give your experience on standardizing sample preparation for MRD, how to successfully acquire 2 million cells.
So there are various protocols published there in literature. The next generation flow protocols of bulk lysis are freely available on the Euroflow website. What they do is they do pre-lysing. The protocol which I am currently using in my lab is the stainless wash protocol. This is for ease of having the same protocol, whether it is for diagnostics and leukemias or MRD. Yes, the challenge of acquiring more cells is there. So the simple tweaks which we have done is a couple of things. Is one, we pre-lysing, the pre-staining and pre-lysing the sample, we concentrate our sample. So sometimes when the cellularity is low, we may take a 1 ml sample, spin, concentrate the samples, get the RBC, WC pellet. And we also end up for MRD using double volume, double antibody samples sometimes. So that's the way we have been able to acquire. Having said that, in a very good cellular bone marrow, the challenge of acquiring 20 to 30 million it's not so difficult. And from our BMR data, we showed that in majority, so I would say 85% of cases with stainless wash, we could go as high as 1 million. I agree that in myeloma, if you need to go deeper, and which is going to be the case, and which I am also personally foreseeing in the future, bulk lysis is going to be the way ahead.
Thank you, Dr. Jyoti. Dr. Jyoti Kotwal is there.
Man was there, but I think
okay.
Logged off.
So we'll take one more question from the audience. Dr. Purnima Kodate wants to know that if Flow has told you that these are monoclonal plasma cells, do you still need to do M protein and beta-2 macroglobulin assays? Beta-2 macroglobulin assays.
Good question, but you have to understand that their role of M protein and beta-2 microglobulin and the flow clonality is different. You do M protein from the peripheral blood. It's important not only for a diagnosis to know the amount of M protein, but also for assessment and follow-up. The beta-2 microglobulin is a prognostic indicator used in the ISS myeloma staging, whereas clonality is a third indicator, in myeloma, again, as I showed, for diagnosis as well as for prognosis. So I think there is a need to do all three. We cannot skip one above the other. And M protein remains very, very important for follow-up, as we know.
Thank you, Kunal. Dr. Alpesh Kumar Kapadia wants to know, can you explain the critical processing steps for cytoplasmic kappa and lambda in myeloma?
So that's a very good and important question. So there are different reagents available for cytokappa lambda, as far as the permeabilization and fixation are concerned. Now, it is to be kept in mind, unlike when we do perm and fix or a cytoperm, cytofix, or whichever company's reagent we use, the same reagent may not work. So it may work for your MPO and cytoC3, it may not work for your cytokappa lambda. So you need to go to take help of your peers and labs and see what reagents they are using. It may be from different companies. BD has it, Beckman has it. I use a Caltag reagent, which is Perm A and Perm B personally. The important steps for both kappa and cytokappa lambda are the pre-washing. The washing has to be done very nicely, and we typically take the washing step not in a 5 ml tube. We do multiple pre-washes in a 15 ml tube by taking a higher quantity of sample. So removing the background proteins, having very good quality buffers, So the PBS, BSA or a sheet fluid is important. And then, the viability of the samples, especially in a private scenario like ours, transported samples are a challenge. We cannot straight away say we'll never get transported samples. We'll get 48 hours old samples and we do process because of the challenge of that sample. But yes, the longer the duration between the processing, the more is more important to carefully look at your red cell lysis. So that again becomes a very important step while doing the processing.
Thank you. Dr. Tina Dadu, your question.
Yeah, hi Kunal. Again, a beautiful presentation as always.
Thank you.
And I would like to ask you that say for example, somebody has an 8-color flow cytometer and you want to put one tube. What are the gating markers that you would want to use and what are the LAIP markers you would want to use? And also that would you like to use CD319 as a mandatory gating marker or no?
So good question. So I would start with the 6 or 8 color tube because this question comes often to us. Now I will also divide the question, do you need surface versus cytoplasmic kappa lambda or not? Now the current guidelines, some of the papers are coming is to do cyto kappa lambda only if required, and you could use aberrant markers like 81 and 27 in your surface tube to analyze it. In personal experience, especially if you're going for MRD, I still bank on my cyto kappa lambda, especially for small populations. As I showed in the caveats, you have a 56 positive, 19 negative populations. When you're assessing MRD, having cyto kappa lambda becomes useful. So having said that, if I'm going to use cyto kappa lambda, 38, 138, 45 is, I think, broadly recommended and used by all. You've taken away 5 markers, and then typically you want 19 and 56. That's where you start from. So you already have 7 markers. Now with 7 marker, when I was doing my 8-color MRD, I had a challenge of whether using 27 or 81. Based on the data and the usefulness at that time, I chose 81, but I would say 27 and 81, it's a very tough call. Going ahead into 12 colors, we added 117, as I said, very useful for identification of mast cells, prognostic marker. You get a good idea of the background matter representation. 319 is a choice I made, again, not from my personal experience, from literature and a lot of help from Prashant. And he said, based on his experience, 319, 229 and other markers, this seems to be working well. I would say 319 and 229, both from the data I've read, are very homogeneously expressed in a lot of other cells. But using 138 along with 319 works pretty well in our experience. The importance of having 319 blindly in all my panels and not using a drop-in, again, is from a very specialized private lab scenario where we may not get that the patient has been given daratumumab. So you need to be careful in analyzing, and then also that by having it there, we are learning how it expresses, on normals and abnormals. So that's very useful.
Okay, so basically by adding 319, you don't want to replace any of the other gating markers. Like if you're using a 319 with the 138, then would you want to replace?
I would think no, 138 would still be far better than 319, though we know that it may be lost in storage. It may have its own challenges, but it's very bright and much better than 319 if independently compared.
Okay.
Thank you, Dr. Tina. Dr. Shyam Rathi wants to ask you a question. He has given a case scenario and he wants you to differentiate between plasmablastic myeloma from plasmablastic lymphoma. That is the question.
Yes, sir.
The scenario is there is a 67-year-old man, acute renal failure, hypercalcemia, hyperuricemia, lambda light chains are 17,000, normal kappa, IgG, IgA, IgM. Normal bones, no lytic areas. Bone marrow biopsy shows diffuse replacement by abnormal plasmacytoid and plasmablastic cells. These are positive for MUM1, CD79A, lambda, and CD45 focal, and CMYC 20 to 25%. They are negative for almost the whole gamut: 138, 19, 56, 117, PAX5, 20, kappa, 3, cyclin D1, EB virus, CD30, and ALK. So what would you feel what this case is, plasmablastic myeloma or plasmablastic lymphoma?
So a very challenging and a difficult case, I would say. I agree that this is challenging based on, I assume these markers have been done on the IHC, the MUM1, 79A, lambda, and 45. So typically, we know that the challenge with plasmablastic lymphomas are that they are often CD20 negative. And that 20 negative makes it very challenging to differentiate between a myeloma, between a lymphoma versus a myeloma, especially in this scenario. The one place where again IHC explains little, but if you have to do flow, the advantage generally would have been that you would have bright to moderate 45 on flow, and you would have the chance of looking at, if the case was a myeloma, typically these may have dim to negative 45, so that's often a useful feature to differentiate the two. It is very difficult on IHC with the 45 being focal to what it is. MUM1 is a marker we know seen in both high-grade B-cell lymphomas as well as plasma cells. We also know that in plasmablastic, there's some kind of redifferentiation to 138 can be lost. Now, I see that there is no M-band, no lytic lesion. Then I would also like to go back to whether there is any chance of this patient being retroviral positive, because the association of retroviral positivity or EBV is higher in plasmablastic lymphomas. So these are the thoughts that come to mind immediately, but I'd like to hear from my colleagues and discussants to what they would do in their practice on such a scenario.
Any comments from others on this case?
Yes, you mentioned about 45, Kunal sir, and another one will be 19 to look at in flow. So I think traditionally 1945 both positive will more favor a plasmablastic lymphoma, and both being negative will more favor a myeloma. That's all I can.
I agree.
What about CD56, Kunal? Plasmablastic lymphoma versus anaplastic myeloma?
So again, presence of 56 from my understanding will be more likely favoring a myeloma. But having said that, I'm sure if you Google it up, you'll find some unusual case reports. But in practice, I would say a presence of 56. But often you may see that, both myelomas may not often present 56, unlike what a textbook say. So, that can again be a challenge.
Very
So
true,
here,
because,
Kunal, I would like to point out that, CD138 is a very good marker in this scenario. If CD138 is not false negative in this case, then our job is much easier taking it towards plasmablastic lymphoma. So that is one very good point in this pointer towards plasmablastic lymphoma in this case, although the reverse is not true. The plasmablastic lymphomas do have CD138, and when it is positive, it is more challenging. I think absence of true negativity of CD138 is a pointer that is taking us towards the PVA.
Agreed, ma'am. Very good point.
Okay, we are discussing the markers, but I have a clinical question. Will plasmablastic lymphoma ever have a lambda light chain of 17,000 and presenting feature being acute renal failure, hypercalcemia, hyperuricemia? As a clinician, this is out and out a myeloma-like disease to be handled as a myeloma type of treatment and not a lymphoma-like treatment. You've got to knock down this lambda light chain as quickly as possible. Otherwise, the kidney will disappear for the rest of the life and the patient will also succumb. So yes, of course, we are discussing more of markers rather than the clinical scenario. We move on to the Dr. Jasmita Das, your question.
Thank you, sir. Kunal, excellent presentation as usual. You did touch upon amyloidosis, and we do face scenarios where clinically it's suspected to be amyloid, and we don't do laser capture microdissections on a usual basis to type the amyloid. So what do you see as the key role of flow cytometry in amyloidosis and in monoclonal gammopathy of renal significance going forward?
So I think it's a very valid question, and actually the case which I showed you, it was the flow was done exactly for this reason, that the patient had cardiac dysfunction. The patient did not seem to be having an M-band in blood, even by IFE. The light chains were not really helpful over there. Fat pad amyloid biopsy was already there, which was positive. The question again was the same thing: secondary amyloid versus primary amyloid. And the patient, being a doctor, was happy to do and arrange all tests possible. So we said, why not attempt a flow? Instead, the plasma cells were only 4%. It was a very patchy hemodilute aspirate. So having read from where we were in that case, it definitely helped us to pinpoint clonality, that there was a primary plasma cell dyscrasia in the background, so it's highly useful. Having said that, the literature also says that even if you prove clonality by flow or you document plasma cells, there may be also cases of a plasma cell dyscrasia associated with secondary amyloid. So laser microdissection still seems to be important. In this particular case, we did do it. There were some trials happening abroad where they are happy to take samples, and we still got it done. It was still a plasma cell dyscrasia, not secondary amyloid. So I think as we go along, both for diagnosis, the role is going to increase for these patients, as well as you rightly said, for MGRS, because we need to diagnose what that gammopathy is, need to know the percentage of abnormal plasma cells and see how it evolves. But yeah, and an institutional basis, if we can collate these cases, look at this data systematically, that will be really a big boon for us all.
And because for MGRS, in my experience as well, having a good number of normal plasma cells in the background of a plasma cell clone clearly tells you that you're not dealing with a myeloma with a low percentage of clonal plasma cells in the marrow.
Very true.
Again, clinically speaking, cardiac involvement is extremely unusual in myeloma and extremely common in amyloidosis. And MGRS and amyloidosis, these are all diseases due to the products of plasma cells and not related to the tumor load. While myeloma is essentially a disease related to the tumor load. So that's a big distinction. If you have very few clonal plasma cells and a lot of, say, kidney disease due to MGRS or a heart disease due to amyloidosis, then these are all not cancers. These are more the functional disorders of the plasma cell producing their product causing the problem. While if you have lots of plasma cells, bone disease, kidney disease, heart is normal, then that's a typical myeloma.
So from one question, how often do you get cardiac dysfunction in secondary amyloid, not plasma cell related?
So, it's an overall picture. So it will be a very late case of myeloma where you will have a cardiac dysfunction secondary to amyloidogenic protein being produced in such a quantity that the myeloma classical clinical picture was not there at all. So if somebody has got a cardiac disease, I will be very careful in calling that person as a predominantly a myeloma-like disease. Of course, having said all that, the treatment of two has become more or less same as far as the anti-plasma cell agents are concerned. But clinically, again, there's a difference. In one, you require cardiac support. In one, you require a renal support. In one, you require to take care of the bones. In the other one, you don't require to take care of the bones at all. So the profile of the organ damage significantly differs. Right. We move to now.
Sir? There was actually in the Western world for the cardiac dysfunction, the ATTR amyloid has also been reported in combination with the monoclonal gammopathy of undetermined significance. So that the ATTR can cause some cardiac involvement. Unfortunately, we do not really have Indian data on the inheritance of ATTR.
True, and you require the electron microscopy with the immunohistology. So that is something Jaslok Hospital and Hinduja Hospital in Mumbai are trying to do. They have the electron microscopy, they have the antibodies, and they do try their best to distinguish between the two. Plus, free services available from Ashutosh Vachlekar from UK for any patient if you want to transport the tissue without any payment, you can have that service. And you can also take help of these two, Dr. Khubchandani, and these are Jaslok Hospital and Hinduja Hospital. Okay, Dr. Gaurav Chatterjee, your question.
Yeah, so I think Kunal sir, you touched on that, the circulating tumor cell. So I was just going to ask that, like, how do you think the role of circulating tumor cell coming up in myeloma, and not only at the baseline, do you think that at monitoring level also the circulating tumor cell is going to be important factor to consider in the cell future?
Very relevant, as I said. It seems to be the future of flow in myeloma, and again, this is coming only out of the data review I did on this topic. How they are pairing samples right from diagnosis to follow up, and that studies being done where they are, as you rightly said, the role is going to be in the monitoring. it seems that the non-invasive nature of the peripheral sampling, the ease of doing, as per the European group, of doing their NGF flow once it's already established, makes it very useful, because from what they are showing, you could, the clinician could gauge or decide on when to do a marrow and when not to do a marrow. For a follow-up patient, for example, if you already have significant amount of circulating tumor cells, it could, make a decision that we could delay the marrow, continue the treatment, and vice versa. So it definitely, the bone marrow MRD levels are much higher and much deeper than circulating tumor plasma cells, but I foresee that there's a role. And I think we should soon have some Indian trials or studies being done on this subject. I suppose your team, you and Prashant, are doing something on this. So we look forward to the data on that.
Yes, we still have to analyze the survival data, but we are.
Yeah.
Just to add on what you said, I think the Spanish, the preliminary Spanish data shows that, of course, like you said, the MRD is more deeper, of course, in the bone marrow MRD. But a significant subset of bone marrow MRD positive patients, they do have circulating tumor cell. And out of all, and so if you have circulating tumor cells still in the peripheral blood, maybe you can relieve those patients from doing marrow, and you just take that as a marker. So that is, I think, where the role is going to be really important.
True.
Thank you, Gaurav. Kunal, there is a very basic question for you. Dr. Meenakshi Swain wants to know what is meant by the word M-band and what are kappa and lambda light chains?
It's a very good and important question. We are going back to the basics. So when you do your protein electrophoresis, you divide your total protein in the body broadly into your say albumins and globulins, and typically when you say M-band, it means a monoclonal band. In the globulin region, we know in the gamma globulins you have IgG, you have IgA, you have IgM, and so on. So if one particular protein, for example, if I have an IgG kappa protein in the body produced by a clonal population of plasma cells, this expands, they start producing the same protein. What you start seeing in protein electrophoresis is the peak, a peak in the globulin region, a sharp peak in the globulin region, which represents one particular protein which is picked up as an M-band. Now, if you go and do the next step, that is immunofixation electrophoresis, where basically you are trying to gauge which type of M-band it is. Is it an IgG, IgA, IgM, and which light chain it has. So I said if it is IgG kappa or IgA lambda, it could be anything. So that is the next step of immunofixation electrophoresis. So this is what we do while doing. So the kappa and lambda are the light chains, part of the immunoglobulin, whereas the IgG, A, M, D, E are part of the heavy chain of the immunoglobulins. And we can separate this, the type of M-band, on immunoelectrophoresis.
Thank you, Kunal. Dr. Abhishek Sharma has a question. Is there a role of doing FCM in a harvest sample of myeloma who is going for transplant? Is there any recommendation regarding flow and what is its significance?
So again, I have not come across this scenario on the harvest sample as such. Pre-transplant myeloma MRDs, we have got marrows as well as MRDs, but unlikely that when you have pre-transplant, when your harvest is being collected and from that harvest sample, when you've already treated that patient, I don't know how that is going to help, and I've not come across the studies. Maybe, sir, you have any inputs on that?
So to the best of my knowledge, there is no data on the flow derived sort of, you're almost talking about MRD being of what extent before doing the transplant, but there is data on PET scan, and there is data on giving consolidation therapy after the transplant based on what was the status of patient before the transplant. So those who have got a PET scan negative, they do better. Those who do not have PET scan negative or who were not in a stringent CR, they receive combination drugs even after the transplant for 2 or more cycles. So probably at this stage, maybe MRD detection, negative, not negative, could make an impact on deciding whether you will do single transplant, double transplant, will you give consolidation, not give consolidation. But this kind of data based on flow is not, I think, to the best of my knowledge, available. Okay. We go to now Dr. Ankur Ahuja.
Sir, good afternoon, sir. A very excellent presentations and a lot of basics and a lot of advanced have been covered. Excellent, sir. So just my basic question is that what is the take of your this thing inclusion of a CD200, especially in the, as a prognostic marker? Because there are controversial studies are there. Some studies have associated with the loss of CD200 with the aggressive disease, and some studies have mentioned that it has a if there is a CD200 negative is there, there is a better survival of the patient. We in our hospital also have done a small size of sample of studies, though it's not that much large, 40-50 patients. So we found that CD200 was associated with some kind of organomegaly, but otherwise we couldn't able to find it out with this thing as a prognostic marker, sir.
So CD200 is an interesting marker, has been used both in the diagnostic and MRD panels in some of the European panels. But so I will come back to a very practical scenario, as I was saying, that clinically, as a clinician, and I am in a private setup where the challenge is, number one, to get the flow sample. Two, how are they going to use the data of that individual prognostic markers? What I've realized is, even though we put it out there that we are doing these markers and these are good and bad prognosis, from a case-to-case basis, it does not really get utilized in a very practical scenario. Having said that, it's good to get this data, and you need a larger number of patients. The challenge again is that as I was going through the various markers, answering Tina's question, 200 was there, as the back of the mind, but the other markers maybe had a slightly more advantageous, especially more on the diagnostic perspective. They may not be having an advantage over the prognosis of 200, but that appeared to be more challenging. So I have not really used 200. Maybe Gaurav has used 200 in myelomas if he has something to add. Jasmita and Gaurav, you all have used Ritumab.
Yeah, we use it in all routine myeloma patients, but like Dr. Ankur said, that the data is conflicting actually about the prognosis, the role of 200 in prognosis. So we haven't looked at it, our own data, like what it is, but yeah, I don't, till now the literature is conflicting on that. It is useful in a context, certain subset of patients where it helps you in getting the abnormal plasma cells, but what's its role in prognosis, the literature is conflicting.
I haven't used 200 in myeloma, Kunal, so.
In fact, if I may add, CD200 and CD28, they have a positivity of 40 to 50% in myeloma cells. So the possible use of them in MRD in the future, I do not know. But CD200, Ankur and I have worked together in this. So we have to generate more data, I think.
Yes, sir.
Thank you. There's a question from Dr. Manu Venkatesan. When giving percentage of abnormal plasma cells versus normal plasma cells by flow, due to dilution and processing issues, is there a minimum number of plasma cells to be acquired, evaluated? Is there a cutoff or any recommended count?
The simpler answer would be more the merrier. In a practical scenario, the answer in a hemodiluted sample is if you end up acquiring more number of samples. So now the question becomes, you have a total of 100 plasma cells or a 50 plasma cells, how many normal and how many abnormal? We do face this challenge if your normal plasma cell cluster is very, very small and less than 20 events. It does not become really a tight cluster. It is difficult to assess, and then to divide it into normal and abnormal becomes very difficult. In those scenarios are rare. Even with frank 60% plasma cells, you may have 80,000 events which are abnormal, and you may still have 200 events, 100 events in the background which are normal. It is easy. The challenge always is to acquire total number of events. So in practice, what has happened is, though I said 2 million or 3 million for MRD, in our lab, the staff directly runs myeloma panels as 2 million events, whether it is diagnostic or MRD. Reason being hemodilution, reason being it could be a plasmacytoma case, it may be a MGUS case, it may be a smoldering case, and we need to divide the bone marrow compartments. So as a routine, the policy we are following is we just run 2 million upfront for all. If it's a known MRD, I might go up to 3 million or as many cells I can acquire with the stain wash. I don't know any recommendations for cutoffs for the same.
Thank you. Dr. Ajit wants to know what is the difference between next generation flow and the conventional MRD flow in plasma cell dyscrasia in terms of number of events and immunophenotypic markers. So
as per the European group or the European flow group, what their data is in the range of 2000 to 2008, 2010 was based on 4-color flow. Then the Euroflow group moved on to 8-color flow. So from 4-color flow, which they label as first generation, they labeled their 8-color flow as second generation. And their next generation flow, that is what they call as the category 3 or the third generation flow, is what they are moving to. Essentially, with the advent of newer machines which can do 8, 10, 12, or even 16 colors now, the number of markers which you can put in a single tube are great, is a far more. As we are discussing the various markers like 227, the more the markers you have, the more diagnostic and prognostic information one can get. In terms of sensitivity, when they talk about routine or conventional MFC, they are talking about 8-color flow. And in MRD, they are talking about reaching a sensitivity of 10⁻⁻⁴, which is 0.01. With next generation flow, they are talking about reaching a sensitivity of 10⁻⁵ and beyond, which is below 0.001.
Thank you. Dr. Shilpi More wants to know how to check the viability of cells and should it be done in all the cases?
So very valid questions. Again, from a practice scenario where you will not get samples fresh. Do we do it? We assess our viability currently in our lab based on forward scatter and side scatter and the way the cells are scattered. We do remove the unviable cells. Whenever the number of unviable cells are significant, one may do a 780 also for assessment because that will be far more accurate. The samples are precious. Would I discard a sample based on any cutoff of viability? Frankly, if it's a very, very important sample, I don't have a spare sample, it becomes difficult to discard a bone marrow. You discuss with the clinical team, you discuss the scenario, discuss the importance, and you run it. But you definitely document it. Now, if you're talking about a completely live sample, which has been kept for 3, 4, 5 days, you would not do it. But if you have a significant degeneration viability in the background, you would document it in the report, saying that there's significant degeneration and needs to be taken care while interpreting that report, especially for MRDs.
Thank you. Dr. Vinayak Chikodi wants to know your comments on CD56 expression being absent in plasma cell leukemia.
So again, there was data which said that CD56 negativity is commonly seen in plasma cell leukemia, and there were various hypotheses for this. That the first slide I showed you was the plasma blast, which moves from the generating from the lymph node, travels in the peripheral blood, and then goes to the bone marrow niche. So 56 is also an adhesion molecule, also called as neural cell adhesion molecule, and has a role to keep the plasma cell in the niches. So it was advocated that once they lose the 56, they may not bind to the niche and they move out into the peripheral blood, and then it's plasma cell leukemia. In a simplistic term, this sounds very good, but I am unsure if that is really true. Okay, to understand markers, to teach somebody about where 56 is present and absent is good, but we have seen even the case plasma cell leukemia, which I showed actually was for that reason, that was 56 bright expression. So it's not always true that 56 can divide between a plasma cell leukemia or negative, but yes, we do see aberrations.
Thank you. Dr. Afshan, you have a question?
So thank you so much for this. So thank you so much for this enlightening session. I'm just new into this flow cytometry. Just started just 1 year of experience, but sir has given very valuable things which I have all jotted down, and I will just keep it in mind, and looking forward for some more enlightening sessions from sir. Since in Kashmir we get a lot of plasma cell cases, so I'll just keep in mind this, the abnormal and normal plasma cell, this is new, we don't do this. So I'll just try it and see the inferences.
Most welcome to call back for help.
Thank you so much. Thank you so much. Thank you so much. And thank you, Agarwal, sir.
Thank you for joining. It must be a good experience for you.
Yes, sir, definitely.
Be with us. Dr. Amit Khurana has a question.
Yes, sir.
56-year-old male, he had COVID infection, and this is day 10. 50% of peripheral blood cells are plasma cells on morphology. There are no CRAF features. Should he investigate this patient for plasma cell dyscrasia or just wait and watch?
I think it would be a mix of a clinical question, affordability of the patient, and how is he doing symptomatically. Doing a immunofixation or a protein electrophoresis, I think, would be the first step. flow is available. And whether these are lymphoplasmacytoid cells, activated lymphocytes, or plasma cells is another question. Flow can resolve the answer, but whether you do that or not would, I think, be a clinical question. I think, sir, you could give your inputs on that.
I mean, very, very unusual situation.
Yes.
50% plasma cells in the peripheral blood as a reactive process. I haven't seen.
Unheard of.
Yeah, unheard of. Almost 40 years, I haven't seen that. So I will be concerned if these are really plasma cells or they are, as you said, plasmacytoid cells. So that will be the first step, really. And Corona probably ask your pathologist to tell you that. And these are plasma cells on morphology. Probably you need to investigate them. And simple things don't cost much. Dr. Babita Sodi has another very simple question. Could you elaborate on what you mean by 2 million events in flow cytometry, as you showed in one of your slides?
I think that was shown in a few of my slides. That is the total number of events we acquire in a myeloma sample routinely in our lab. So it was shown in all the cases that we try and do a cell count when we get the sample. We assess how much volume of sample to take for processing, and we target 2 million events. One of the other reasons we were targeting 2 million is, the data processors of the current day computers and the software becomes very slow. The data has to be, backed up and processed, and it's a very challenging scenario once you start going above 2 million events. The 2 million events are basically the total events of which we take the we remove the degenerating based on FSC, SSC cells, and you saw in few of the plots it was around 18, 19 lakhs. Then we look for MRD or the plasma cells. So the number of plasma cells becomes the numerator. The viable FSC, SSC cells becomes the denominator. 20 lakh cells acquired is also to give to the person reading the report an idea of how much did we acquire. And if the degeneration is very wide, you will see the FSC, SSC being only 10 lakhs. So that means 10 lakh cells or 50% of what you acquired was not viable. So reading that report for a colleague, for a pathologist, a clinician can add a lot of value.
Thank you. Another basic question by Dr. Vishwadeep Khushu. When do you use the term monoclonality based on kappa lambda or any other feature on flow?
So on flow, typically clonality assessment for B cells, traditionally when you said B cells, they would say these are clonal plasma cells. It would have been said it is kappa or lambda. Can I identify clonal plasma cells without kappa lambda? Yes. A very simple answer would be, for example, a CLL. If you have a large majority of cells which are 19, 5, 23, bright 200 co-expressing, those are clonal plasma cells. You really don't need to prove clonality by kappa lambda. And I think in the current ERIC CLL guidelines are actually doing that. You don't even say to do cytokappa lambda or surface kappa lambda. Similarly, for myeloma, you could use other markers. So you're using different from normal approach. You're looking at aberrations of cells which are not present on normal cells to assess that these are aberrant or clonal abnormal cells.
Thank you. Dr. David Y from Australia wants to know, what is your explanation for discrepancies in myeloma numbers by flow as against trophine biopsy, IHC, staining for CD138?
So 2-3 factors as I discussed in the scenario. One, myeloma is a patchy disease. Plasma cells generally love the lipid spicules and the lipid fat particles. They tend to aggregate. We all see that even in aspirates as well as in biopsies. So biopsies, you may see only 2% on an aspirate, but another area on the biopsy may show you a whole sheet of plasma cells. It's not uncommon. So you have to do a complete picture. Second, we know there is some amount of loss of 138 for its been example has been described on storage of samples stored in the fridge with 138. Use of heparin has impact on the 138 expression. Also, if you do cytokappa, cytolambda analysis, you are going to have loss of cells. However, keeping all the factors in mind, the biggest factor is hemodilution and variation in the sample. You can go back and see your direct smears, which showed you possibly 50-60% plasma cells, and make a good well-spun smear from your EDTA or your heparin sample. You might see only 15% plasma cells. So the liquid suspension is what goes into the flow, and then you have other artifacts. So then there are numerous reasons, and hence one cannot rely on the actual percentage for on flow to diagnose which category of plasma cell neoplasm it is. For that, we stick to morphology.
Thank you. Dr. Krishna Ratnam wants to know, IMWG criteria talk about clonal plasma cells. So does it mean that in every newly diagnosed case of myeloma, you have to document clonality?
when I read this earlier, I had a similar question and I thought it's not really defined, but when you go deeper into the literature and articles and from where this message is coming, it was typically based on clonality by IHC. Even the stringent CR of IMWG says less than 5% plasma cells and then doing clonality on IHC assessment. Having said that, with 5% plasma cells, doing it on IHC is practically very, very difficult. Even with 10% plasma cells, sometimes it is very, very difficult. Keeping aside the fact that IHC kappa lambda again is a very difficult technique, not very easily to standardize. So yes, long term, if you ask me, I would prefer flow over IHC. But the current definition does not state that. It is just saying clonal plasma cells by whichever technique you use and whether it is less or more than 10%.
Thank you. Dr. Muhammad Hussain Mir wants to know, is there any difference in flow cytometry markers in different type of myeloma? For example, IgA myeloma, IgG myeloma, light chain myeloma.
So it's a very interesting question. To be frank, I've never looked at it that way, and I would like to go back and look at the data whether there were any markers. I have not come across the same in literature. Would ask my other colleagues if they have looked at it this way. It's a very interesting question.
Anybody wants to add?
Not that I am aware of there is any difference, but I guess it will be obvious from M band and immunofixation. So, I mean, you don't need to really look at the marker to come to this conclusion.
And sir, I agree. There is as such no difference with respect to the M band and the immunophenotype. IgM, of course, the Waldenstrom macroglobulinemia is a separate entity altogether. And sometimes when the lymphoplasmacytic cells are more, it may cause a confusion with myeloma. And we can always resolve that by looking at the abnormal B cell clone as well. So with respect to the previous question, I would like to say that there are clinical scenarios in which you are suspecting a myeloma. For example, a person who has presented with hypercalcemia, calcium levels of 12.5, say, and the bone marrow shows you 20% plasma cells. And I burned my hands on this because the bone marrow is showing 20% plasma cells with this level of hypercalcemia. I put it down as a plasma cell dyscrasia and we did not run a flow on that. Now, a week down the line, a flow was run because the sample was drawn to send the myeloma fish panel. And we realized that all the plasma cells are actually polyclonal. So that is why even in the typical clinical scenario, sometimes running a flow is beneficial upfront rather than labeling the patient as myeloma and then, treating it and really not getting anywhere.
Another question Dr. Mir has is, can we do flow cytometry on peripheral blood in an active case of multiple myeloma? And does it have a prognostic value? It has been discussed multiple times today, but you want to answer anything?
So we already discussed the circulating tumor plasma cells.
Sure. Fine. That's the end of the question from the audience. If the faculty here has any more questions. Any one of you?
I actually had posed a question on the mail, but that has been answered in the slide. So I'll just reframe my question. Any method of differentiating long-lived plasma cells from tumor plasma cells? You mentioned that in your first slide, but the flow aspect I would like to know.
So sir, there is some data. If I can, happy to share you the review article on the circulating tumor plasma cells. So they are trying to say the stem cellness of the circulating tumor plasma cells or the long-lived plasma cells, and these are being identified, as the 19 positive. Say the 81, the 19 positive plasma cells, because when they move from plasma blast, they are 19 positive. By the time they reach the marrow, they become 19 negative. So the hypothesis of the European group, which they are portraying, is the plasma cell development actually happened in the peripheral blood, and these plasma cells in circulation, some of them do have the 19 positive phenotype. So hence, if you see the bone marrow myelomas, which you see, are commonly the marrow niche phenotype, the 19 negative, 56 positive. Whereas the rare ones are 19 positive. So they are attributing these to be the long-term plasma cells. How true that is, or how it will come into the being, because then the question will always come, we always have aberrancies in myeloma. How sure you are that this is actually a true plasma cell? There is not one definite marker. They are using 2 to 3 markers and they say this may have potential things. I think it's still time will tell us whether it will hold true or not.
One more question has come up from the audience. Dr. Prerna Arora. How MRD will be analyzed if the patient has biclonal gammopathy? What's your experience of flow in such cases?
So we do come across cases with biclonal gammopathy. Again, from a phenotype wise or a flow wise, you may not really find two clones, you're finding abnormal plasma cells. They would generally cluster together based on aberrations. Like you may have subsets of plasma cells. For example, I showed a case 56 positive, 56 negative. One just needs to keep in mind that the same thing can happen during MRD. You may not have a diagnostic myeloma having 56 positive, but small subsets of negative, and the same may persist after therapy. I don't have personal experience of looking at biclonal gammopathy, but I practically don't think it would be a problem when you're analyzing MRD.
May I expand on that?
Yes, ma'am.
See, when we are talking of biclonal gammopathies or biclonal myelomas and doing an residual disease analysis, and then we are looking at two aspects. Now, there are these plasma cell proliferative disorders who have two different clones with respect to their immunophenotype and the levels of the light chain expression of the same type, which means that if it's a lambda light chain restricted case, it will have lower amount, some of the cells will have lower amount of lambda light chains, whereas others have higher amount. And this we see because we do, if you recall our standard immunofixation, we do get the results that the patient has IgG lambda plus lambda free light chains, even on immunofixation. So when you see such cases on flow cytometry, they have different amounts of the lambda light chains, or if it's kappa restricted, within the cells. So flow cytometry is a good tool to identify these as separate, even at the time of MRD, because your primary gating for the APC or the aberrant plasma cells is based on the abnormal expression of the surface antigens. Now, the second part is where you have a kappa and a lambda as two different clones. One is kappa restricted and one is lambda restricted. So in this scenario, the surface antigens become very crucial, because when you are gating the APC based on the aberrant surface expression of markers, you can clearly see that one population is showing the kappa light chain restriction and the other aberrant population is showing the lambda light chain restriction. So flow cytometry is in fact more useful than your conventional immunofixation, as well as the serum free light chain test to assess response. So this is a very unique, there is a very unique role of flow cytometry in biclonal myelomas and gammopathies.
That was very valuable, ma'am. Thank you.
Thank you. Now, Dr. Vishwadeep Khushbu has added a part to his question. He had asked you a question: can we use the term monoclonal when we actually check kappa lambda as monotypic plasma cells? When to use the term? And he wants to now add to that question that my question was that clonotypic can be labeled as monoclonal or no?
I'm not sure I understood the question, sir.
So if you have a clonal myeloma, can that be called monoclonal?
Kunal sir, I think what he's asking is, based on kappa or lambda restriction, can you call it monoclonal or are you going to call it monotypic? I think it's basically an academic question, because there are some, I think, scenarios where it has shown that monoclonal by flow that may be genetically polyclonal. So unless you are doing that level of genetic analysis, there is no way really to separate the two, and you will probably have to level either of the way.
And this question comes mostly from the basic sciences and immunologists who do not take our, the way we decide clonality clinically on kappa lambda light chain restriction. They don't accept, the immunologists don't accept our definition of clonality. But I think we are doing this purely for the clinical scenario where it is valid and applicable. And whereas when you're talking of basic science research, and like Gaurav said, from pure academic point of view, I think the question is very, very valid.
Thank you. We just have a couple of minutes left if anybody has anything for Kunal.
Can I make a comment,
Yes.
Dr. Agarwal?
Yes, Dr. Neelam.
Yeah. Kunal, excellent presentation, very well done.
So much.
I think among your very initial slides, I guess 7th or 8th slide, where You were showing a case you came across about 15 days back or something like that with
Yes.
the lymphoplasmacytic morphology, and documented 54% abnormal plasma cells. So was anything else? Are you aware? Any fish or any other molecular testing was done? Because
So, ma'am,
myeloma.
it was actually the case 10 days ago that I'm still awaiting the report. So
Okay.
it came to us as a suspicion of a lymphoma with atypical lymphoid cells in the peripheral blood.
Yeah.
So I actually asked the clinician to send me the peripheral blood. I have not got it yet because my worry was, is it actually a plasma cell leukemia now? Because if someone has reported, they are there. The bias was that, by cytopenia, and I got a call that it's a high grade lymphoma. It was a late evening sample. I just saw the slide for morpho and gave the flow panel. We followed up. The M-band has come positive as expected. They are doing the skeletal survey. I have not got the report yet. The fish has been sent for myeloma. We are awaiting the results now.
Yeah, so would be interesting to look for translocation 11, 14, something like that, which is associated with lymphoplasmacytic morphology.
Yes, ma'am.
Yeah. Okay. Thank you.
Thank
Bye.
you.
Thank you. So before I ask Paresh to give the official vote of thanks on my behalf, on behalf of MHG, let me thank Kunal and all of you for a very, very active discussion. And special thanks to Dr. Neelam for being our guest today. So Paresh, over to you.
Thank you, sir. Thank you, Dr. Sehgal, for the fantastic presentation. And on behalf of Pharmafer, I wish to thank you all for the active participation. And also a big thank you to Professor Dr. B Agarwal for making Pharmafer a part of such a fantastic session. Thank you. Thank you to all, and a very good day.
Thank you, everyone. Thank you, sir. Thank you, Neelam. Thank you, everyone.
Bye.
Bye, ma'am.
Bye.
Thank you, sir. Thank you, ma'am.